Bore da bawb, John Williams dwi, Cadeirydd y Bwrdd Iechyd Ysgol Bai Abertawe. Ar rhan y bwrdd, croeso cynnes i'r cyfarfod y bwrdd bore yma. Croeso arbennig i Abi Harris ac i'n gwest 200 llais, Helen Williams. So good morning everyone. I'm Jan Williams, the chair of the board at Swansea Bay University Health Board. And the board extends a very warm welcome to everyone who will be joining our meeting today. We extend a particular welcome to Abi Harris, who's with us as Chief Executive for the first time, and to Helen Williams, who's joining us from Llais. Delighted to see you, Helen, and hopefully you'll be able to be with us from every meeting from now on. So very pleased to see you. So the Health Board is a strategic population health body, and the board has a statutory duty around health protection and public health. So we'll always have an item on our agenda around this responsibility. And today we're including a presentation on vaccination and immunisation. And of course, vaccination saves lives, and it's one of the most effective ways to prevent serious illness and disease. The board must look to the future and set strategic direction. And today we're taking a wide-ranging paper on mental health and learning disability services, keeping population health firmly at the forefront of our thinking, as we set out the ways in which we're going to look at modern mental health services for the future. The board also has to build and sustain strategic partnerships. And today we're looking at the 50-day challenge as a partner body in the West Glamorgan Regional Partnership Board. And we're also embarking on a new collaborative venture with our neighbouring health board, Hywel Dda. And we have a paper today that sets out the basis of a joint collaborative committee as we design a regional health economy for South West Wales. We also have to set the organisation's strategic risk appetite, agree those strategic risks, and then oversee them. And we're having a look at our strategy today before the board does some more detailed work in a development session in December that we'll bring back in January. So as well as looking to the future, the board has to scrutinise and oversee delivery against in-year plans. And this section of the agenda is always very weighty because there are some really important issues. And as board members, we also must understand patients' experience of our services. And our patient story today concerns child and young people mental health services and the ways in which our OT service can assist with that agenda. And it's very relevant and speaks to the paper we'll have later on mental health. At month 7, we have significant financial challenges, and there's a detailed report on our agenda today, which we will be discussing in some depth, because the board has a requirement not to exceed 50.1 million deficit at the year end. We have no approval to exceed that sum. So these are very important considerations for the board. We'll also be looking at all aspects of our in-year performance, and we'll particularly be reviewing the winter plan. And we do so against a backdrop of significant pressures, as Abi Harris will be talking us through in respect of our unscheduled care services. I mentioned the 50-day challenge, which is very much part of the winter planning preparations, and we'll be taking a detailed look. We spend £1.6 billion of public money as a board, so we have to ensure good governance and that we discharge our stewardship role properly. The board relies very much on the work of our committees, and we are looking today at a new way of reporting from the committees, the AAA, the alert, the advice and assurance to the board, and delighted that we're having the first report from the Data, Digital Research and Innovation Committee, and as ever, appreciative of Jean Church's agreement to chair that. So our governance section will also include updates on maternity services, and we're putting mental health services under the governance agenda because we're going to be subject to independent review in respect of these services, and some elements will come outside the normal management arrangements. We also, with our staff, set the tone and culture for the organisation, and you've heard me talk before about the fact the board wants everyone to come to work, be their best authentic selves, and not fear sort of disadvantage or discrimination of any kind. And we also want the board staff to engage with us. We're in the dying days of the staff survey, and I'm sure Abby will come on to talk to us more about that. So a very weighty agenda today, and if the board needs to take a little more time than we would otherwise schedule for specific items, we're going to, because it's such an important agenda to talk about. So if I now turn to that agenda and the apologies for absence we've had from Andrew Jarrett, Larissa Vaughan, Judith Vincent and Nuria Zoleh. May I ask board members, please, do you have any declarations of interest in respect of those matters on the board agenda today outside those we've already declared on the register? Keith.
Yeah, I have a declaration of interest around the paper on mental health services. I have an honorary contract with the health board and work part-time in that service.
Thank you very much, Keith. Nina?
Yeah, I have a personal interest in the same item 5.6 because one of the reports in it related to a personal friend of mine.
Thank you. So, Rena and Keith, you're very welcome to contribute to the debate, but what you're not in a position to do is take part in any decision making. Is that okay? Thank you. So it gives me great pleasure now to ask Abby to introduce her first Chief Executive's report. Abby, over to you.
Thank you, Rajan. Thank you very much. And it's a real pleasure to be here to be presenting the first report. I'm not going to go through the detail, but I did want to draw your attention to a couple of points in the report. The first thing I wanted to say is that I'm in my 5th week, and I did spend a bit of last week, or in fact most of last week, away from the office, visiting the healthcare system in Denmark as part of the Aspiring Chief Execs programme. And I'll bring something back to the board on that, about the learning from that, because it felt like a bit of a luxury going so soon into my time here, but actually there was some really good learning. And I'll bring that back if we've got time at the board development session in December, so that was really helpful. And I'm really grateful to the executive team and all the team colleagues I've met out in the organisation in my first few weeks. The welcome I've had has been very warm, and people I think have been very candid and open about their experience in working with us. And I'm really encouraged. I think you've talked about this, John, about the potential we've got in the organisation and moving in the right direction on all of our agendas, which we'll focus on as part of the conversation today. A couple of things just to say to draw out from my report. Clearly, making sure that we have the exec team that we need in place is progressing. And as I've confirmed in the report, Liz Ricks has been appointed as our nurse director and will join us at the end of the financial year. England has a 6 months notice period for some of the trusts, and we've not been able to secure earlier release. And hopefully next week we'll be able to announce the planning director post. So we've progressed that through the appropriate process. So hopefully the individual we have as the preferred candidate will be joining us in early February as well. And obviously we have the workforce and organisational development appointments coming through shortly, which will help us. Final thing to say in terms of the team is we've had Jennifer notification that you are moving on to pastures new. I think we've let board members know, and we'll have a time to acknowledge your contribution, but to say that also means that we need to progress at pace in relation to making sure we've got the right support we need around our population health and public health responsibilities. If I may, John, just 2 other things to highlight. The report talks about targeted intervention, and we have a separate report on that, and there are separate meeting arrangements in place with Welsh Government. And just to put on record, since the board last met, we have been escalated to level 4 into targeted intervention for finance and planning, which was not unexpected in terms of where we are in our position. And I've had the first meeting with Olivia Shorrocks, who's the lead in Welsh Government, to talk through what support we might want as part of that targeted intervention. And I've a letter to go back to Judith Paget now. I've had that conversation that will firm up what our ask is in relation to that. Just touching upon the emergency and urgent pressures, just grateful to staff. We have had very significant pressures over the last few weeks in our emergency and unscheduled care pathway that's resulted in delays at our front door, delays for responses to ambulances in the community, and delays in terms of moving our patients through the patient pathway. And yesterday, HIW commenced an unannounced visit, which will be a 2-day visit in the emergency department. And we're supporting them to make sure they've got access to what they need to make sure that their inspection is as complete, as thorough as we need it to be. And Deb will talk a bit more as we come to the TI report and the performance report about where we are in relation to that. The other thing that's happened since the board last met was our JET meeting, and just to say that the executive team did a really good job in terms of giving account of where we are as an organisation across the full breadth of things. Yes, we do focus the conversation on the targeted intervention areas, but actually it was an opportunity to describe the broader range of things that we are doing as an organisation. And Chris, things like the conversation about women's health and the work we're doing in response to the draft Women's Health Plan was really encouraging, and we got support for that. And it was also an opportunity to talk about things like our digital maturity and some of those agendas that perhaps quite often don't get the viewing in some of our other conversations with Welsh Government. Final couple of things, if I may. The Compassionate Leadership Pledge is in the report. I would be really grateful if we have board support to sign up to that. That's on the back of the work that Michael West has been doing in NHS Wales that I'm sure you are very familiar with. I do carry around Michael's book in my back pocket, as it were, in terms of the reminder of just how important that work is and the tone of our conversations with our staff, and the leadership expectation from us all in terms of compassionate leadership. So it's really good to see a pledge coming forward where we're explicitly making a commitment to that. And then the final thing is just gratitude to staff. We've had a difficult week, both in terms of emergency pressures, but responding to a couple of incidents. We had a fire in Glanreed Hospital last week, and very grateful to the way that the staff responded to that, to make sure our patients were kept safe and that the staff were safe. And just to say that I'm going to visit the service on my way home this afternoon, and we'll have a better update in terms of the implications from a physical point of view and what that means for a service. And again, I can touch on it if people have got questions when we come to the mental health item. Jan, that's all I wanted to say. Happy to take any questions on any of the specifics.
Thank you, Abby, and your written report and your sort of update to the board covers a lot of that. Are there any comments, questions for Abby? Be happy to receive Abby's report, and thank you for that. And I'm sure we will fall into on a number of the items that meeting progresses talking about. So if we turn now into our patient story from silence to stay. Chris, over to you.
Okay, this is a story of a young girl. We don't have any occupational therapy services within our CAMS, child and adolescent mental health services within Swansea, and OT have been working alongside CAMS with a few cases to assess and evidence the benefit and the impact that occupational therapy can make. And this is one of those cases. The family felt very well supported by the CAMS service. They were already involved to discuss the young girl's mental health, but they struggled to apply advice to practical day-to-day changes in the context of home and school, skills of daily living, independent living skills, bathing, wearing uniform, getting to and attending school. The family felt very let down by the education system and lack of acknowledgement of her needs at primary school level. So there was no handover to comprehensive school, meaning no adjustments were in place, which was the main reason her school attendance broke down when she started comprehensive. The family felt that she should have been on an autistic spectrum disorder pathway many years before this, and are frustrated that if school don't acknowledge difficulties, they're unable to be referred, they don't have a pathway, they don't have an assessment, and they feel that this significantly delayed her accessing the correct help. Selective mutism is still widely misunderstood in the children and young people population, and speech therapy had been available and identified and supported the family, and this was pivotal in how they explained her needs to others. So I think if you show the story, and then I'll come back on what happened, the actions taken, the lessons we learned, and what happened after the story.
Yeah, Chris.
Georgia always struggled from a very young age with social interaction or speaking to people or anything, so was always quiet and withdrawn. carried on right through primary school and never really identified as an issue within the school, even though we could see it at home. So it was always a struggle to try and get any support for her. But to year 5 and 6, and then there was anxiety. She really started deteriorating, got much worse, became withdrawn. At its worst, it was intrusive thoughts, paranoid thinking, and self-harming. Self-harm is difficult to deal with, but I think it's easier for the self-harm to reach out and ask for that help. As far as the paranoid thinking, where believing her mother were trying to poison her and would only eat pre-packaged foods that she'd taken from the fridge herself, that was a real difficult time for us as parents, and reaching out for help with that was terrifying. It's really difficult to phone healthcare professionals, tell them out there that your child thinks you're going to poison them when they need help. That for us was, as parents and as a family, was really rock bottom. We just had nowhere left to go. We didn't know what else was the right thing for us to do next. We attended the sort of generic parenting courses we were suggested for, or any of the usual things we were sent to, and none of them really had any effect with it, because really we were doing anything they told us to do, and anything we tried with Georgia, she was unable to engage with. It had a massive impact on our 2 other children as well, where we're having to disrupt them just having what would be a normal life, and some resentment there of just, well, we can't go and just have a normal day out because Georgia can't stand in line to do this, or we can't go on a holiday somewhere because Georgia can't stay somewhere she doesn't know. We did have then CAMS in reach, came in and seen her towards the end of year 6, and they advised then that we refer to occupational therapy. I think it was supposed to be for a one-off appointment, and after speaking with us, they invited us then to attend the parent sensory group, which was amazing. It really helped us to understand just how Georgia processes the world, really give us a better grasp then of just what she's dealing with every day. Sian came out to the house, spent a fair amount of time as well, just getting to know Georgia and doing things, and helped develop coping strategies for things like just having a bath if she couldn't deal with the feeling of being wet, or things as simple as just sleeves so she could wear a school shirt or anything just so she could wear the uniform. And I think she really helped with making sure that Georgia's voice could be heard, even though with the selective mutism she couldn't actually speak to anybody. They also then worked when she went to comprehensive and was struggling to find her way around school, that after hours took Georgia around there just practicing her route from different lessons so she knows which way the doors open or which sort of set of stairs she needs to go down because it's going to be quieter. Things with dealing with getting on the bus, how she's going to identify which bus she needs to get on. After that, I think it was a really difficult year through year 7 for her, of very attending school as she should be. But this year she's attending on a reduced timetable, but she's up to 75% of her timetable and attending that regularly. She's able to get on the bus on her own at the end of the day. She's picking up more of her homework and classwork or anything now as well. What's been really important has been all the different agencies working with Georgia and all coming together. So it's speech and language, CAMS and OT working with the school. As well as that, I think it's helped with the boys to understand really how Georgia feels, and it's really made a difference that we're now able to go on a holiday or go on a family day out and just make the necessary adjustments so that Georgia can participate and enjoy, and the boys don't have to miss out on those things. As parents, the support has been just invaluable. OT were just a real lifeline for us at a point that we really didn't know what else we could do.
Yeah, we didn't have an occupational therapy service within CAMS. And this was an example of a multidisciplinary team working outside their traditional roles and a patient-focused approach, and worked outside the traditional roles and boundaries to meet complex individual needs of the young person, and was key in progressing to get Georgia to return to school and understand a supportive school allowed progress. This sadly isn't always the case, and AHP roles within education, allied health professional roles within education, can support this relationship building and collaboration. We have good speech language support to schools, but we don't of other AHP roles. And CAMS InReach was also vital to this going into the school. The children do fall through the gaps of the Additional Learning Needs Act, because if their needs are not clearly identified at primary school and they don't qualify for an IDP, an individual development plan. Educational placements for children with potential emerging but undiagnosed neurodivergence and mental health needs who don't have learning difficulty behaviours, the challenge are still very much non-existent. So if they've got challenging behaviours, they do tend to get support. And during the long period of meetings to decide how to get the child back to school, schools offer very little by way of learning packages to pupils who are refusing to attend school in person. So super schools are increasing environmental demands for children who are neurodivergent, too big, too loud, too busy, open plan, limited places for downtime, and virtual classrooms could be very valuable to these children and young people. AHPs can help to identify needs at an earlier stage and work in collaboration with families. So since this story, CAMS have recognised the need for OT input into their team and are supporting the development of OT posts. A post has been developed within Hillside Secure Unit for young people, for an OT, and young people that reside in Hillside often have undiagnosed, unsupported neurodiversity, including development, coordination disorders, sensory processing, and emotional regulation. All of these areas can be supported by OT and a multidisciplinary team. School avoidance has increased a lot in recent years, and many children and young people can't access mainstream education, and they often end up unemployed and supported by youth justice systems. And occupational therapy is passionate about supporting these young people, improving participation and functioning into adult, and preventing the need for justice systems. The whole point of this approach is to work preventatively, and it has been recognised by Meath Talbot LEA and the impact they can make in pupil inclusion units and engagement in learning improvement. And an OT within comprehensive schools is being piloted by NPT LEA as well, and 2 part-time OTs have been appointed until the end of the year. So, because she didn't have needs that disrupted others, I think that was part of the reason that this doesn't get looked at. And while this case has a very positive outcome, and lots of what's done isn't part of our core practice and our core offer, and there is a lack of established AHP entity pathways within education. So, which is something that through our work on neurodivergence, autism, the additional learning needs is what we are trying to improve. She was able to return when she had an IDP and reasonable adjustments, and is doing very well. So thanks.
Thank you. Thank you, Chris. Very sobering patient story there. I'm really pleased at the outcome for the little one involved. But as you say, it's a much bigger issue, isn't it, really? So Hazel, shall I start with you?
Yeah, I've really enjoyed listening to that story. Thanks for sharing. I think it highlights a really important point from a family's perspective about how challenging it can be to ask for help and some of the stigma that's around some of these services. And I think it's really key to successful intervention for that young lady that the family is involved. So I think there's definitely something for us to take forward into the transformation work that we want to do in the paper later around mental health, about just being really clear about the importance and that focus on making it as easy as possible for families to ask for help and get supported as part of a family-centred approach to mental health.
Annalise, please come in.
Thanks very much. It was a very touching story. My understanding is that it is actually, at the moment, it's very difficult to recruit occupational therapists anyway. And I don't know whether that's across Wales or particularly here, because I know there are some gaps. And I just wonder, because that sort of service, the interaction with the local education authorities and CAMS, I just wonder about funding and whether that's stymies any progress for the time being. Because I know with my school governor role, how many children are avoiding school for various reasons, and the rise in the selective mutism as well, where this sort of help is really critical to get them back and on track, and so that they don't fall out of education.
Yeah, so quite a few of our allied health professional roles, we do have issues with recruitment, but I'd say we haven't got a massive recruitment with OT at the moment. It is in particular services or in specialism, and people need to develop specialist interest in these areas. So I think that's part of it, is you know, in that. We have very good working relationships with the local education authorities in terms of developing roles and how they work. But I say speech and language is well established within schools. Occupational therapy, maybe not as much, and where there are joint roles or their health roles or education roles and how we support those. So I think there's still quite a bit of work for us to do in that. In our additional learning needs work and our neurodivergent work, we've got very good participation with education. We work very well with education in this area.
Thanks.
Please, Helen, do come in.
It was nice to see the multidisciplinary team come together and work, and it was patient focused. And I was just thinking, how much more could you do bringing in education as a multidisciplinary team within the health board?
They do participate very well with education, and we work very well with them. But I think it's more HPs outreaching into schools, because it is in the place they're educated or into homes. So I think again it is in a team to identify the gaps and the skills you need in that team. So occupational therapy is particularly useful with this group of children, and so I think we traditionally haven't had that in our, and that's what we are trying to develop now.
Just one more of the statement. We're doing a piece of work with children and young people who are accessing CAMS or who can't access CAMS, and that might feed into your mental health CAMS paper, strategy when it comes along, and we're happy to help wherever we can. So there's a large piece of work going on with CAS in Swansea Bay on that.
Thank you, Helen, and we look forward to receiving that. So we've got Keith, and then we'll finish with Abby. Keith, do come in.
I mean, thank you very much for the story. It's a very moving story, and it does really emphasise, as has been said, the multi-agency, multi-professional nature of how to give these young people the right start in life and to make the most of their life chances. It's really good to hear that there are some community OT roles funded until the end of the year. I wonder if it's possible to give any assurance about their continuance, but also to just to point out that at Swansea University we've recently begun to train occupational therapists and look forward to working very closely with the Health Board about ensuring a supply of occupational therapists across the service.
Yes, thank you, Keith, because I think that sort of pipeline is really important, isn't it? And the opportunity for local people to train in the university is excellent. Thank you. Abby, shall I ask you to conclude this then in terms of what we'll be doing now?
Yeah, thank you very much, Chris, for bringing the story, and very grateful to Georgia and her family for being prepared to share that with us. It's not an easy thing to do, to share publicly your family story, so if we can pass back our thanks from the board to the family. And for me, there are two things really. Hazel, you touched upon it, the impact on the family and the whole family and those other children in the family and their journey as part of this as well. I thought that came through really well in terms of the story. And for me, the bit about making sure we've got the full complement of staff we need in the multidisciplinary team. And Dev, it's a similar point about the workforce mix. It is also about therapy assistants who will have a very important role to play. So it is about the qualified staff, but it's also about the staff we've got supporting those and making sure we've got the skill mix. And we need to make sure we are able to continue this model moving forward. So Keith, your question, that's what we need to come back and get assurance about how we make sure this is a model that we can continue. Because just seeing the journey of Georgia and how she has been improving and able to enjoy and participate in things that she couldn't before is just a really encouraging story for us to hear. So thank you, Chris, for bringing it.
Thank you again, Chris. And so we'll relay our grateful thanks to the family through you, Chris. And clearly we'll be picking up this work as part of our broader work on mental health. And Keith's question around sustainability of funding options that we have on a non-recurrent basis as part of that work. So Jennifer, should we turn to you now then, please, and the presentation on vaccination and immunisation.
So as you've already, as has already been laid out, this is a really important agenda in terms of how we protect the health of our population and prevent serious illnesses that can arise and that can have a significant impact on people's lives. So what I wanted to bring through today is not a complete run through of the totality of the immunisation programme. It was really designed to demonstrate some of the key elements of what we're learning through the implementation really of our vaccine equity plan, and in order to help us understand what are some of the drivers that our population are experiencing that leads to and contributes to the differential engagement and uptake. Just to provide a little bit of an overview, there are 3 broad schedules. They cover a range from 8 weeks to 75 years. There are routine immunisations, there are selective immunisations, and then there are those that we also provide additional vaccinations for those who have underlying medical conditions and deemed at higher risk. And in our provider landscape, that is diverse. We have primary care, our GPs, we also have community pharmacies, we have school nursing, we have the immunisation and vaccination team. So there's quite a flex there, therefore, which is one of the positives around that. And those are all differentially involved in different parts of the immunisation schedule. So what I've then laying out here are just a few of the programmes to illustrate some of the key points in terms of how we understand the differential engagement and uptake. And there will be a common theme here, which is often around this issue of deprivation. And it is mainly because that is the way that we tend to capture and record and present information. But what the immunisation and vaccination team in particular are doing with partners is then scratching the surface of that and saying, well, what more can we understand? Because actually, whilst we have a population health strategy and we understand our contribution in terms of shifting the dial of a fairer society with less of that inequality in deprivation terms, there's more that we need to understand of what sits underneath that, because ultimately that's a statistical geography. And so some of these are there to illustrate that. And the other, therefore, element that I've tried to demonstrate here is how we understand it by GP cluster, because that then gives us a different geography within which to look at, and also because they are part of the provider landscape. And so you see some figures here around the MMR programme. On the right-hand side, that demonstrates that across the whole of Wales, we see this consistently, and it's not just in Wales, it's in the UK. You'll see this differential engagement and uptake by deprivation. And in our GP clusters, what you might notice actually is that some of those GP clusters that we may assume therefore have the higher levels of deprived communities aren't necessarily at the bottom of the scale in terms of engagement. And I think that's a point for us to come back to. Similarly, with the COVID-19 vaccination, you'll see a similar trend. And that's what I'm trying to sort of relay here, that these are consistent trends, but later on I want to try and then get beneath the surface of that. This is another example, and again, it reinforces for me the point that primary care and GPs are our primary mode of delivery, but they're not the sole mode of delivery. And so when you look at the differential across the clusters, again, as you know, as I was saying, the fact that there are upper valleys, for example, I would call that one out, an area of high deprivation, but actually doing remarkably well in comparison to some of the others. And some of the learning from what we're gathering this year by now having the vaccine equity plan in place and having a vaccine equity group, which is bringing a wide range of the stakeholders together, is that there's a differential approach that is directly related to a number of factors that would be playing out at primary care level. And that can be the size of the GP surgery, it can be the level of priority, it can therefore offer, it's about the heterogeneity of the offer that needs to be given when you have differing levels and different types of population groups within your registered population. And this again is by deprivation. So it's getting underneath that element of understanding it by the geography that we can understand locally. And the vaccine equity strategic plan, which I've referenced, we brought in for that very reason. We recognise the different engagement and uptake, and we wanted to understand that better. And that set of actions within that, underneath the top headings of identify, understand and apply, is what we're applying this year. It tries to shift away from a simplistic understanding of access being the main determinant that drives the unequal distribution of engagement, of being just purely about proximity. So what this is starting to demonstrate, it isn't just about the proximity. Proximity does play in, and we see that where we don't have primary care, we don't have our GP surgeries involved, then we're having to find different solutions to make it easier for that population to be able to get to somewhere that's local to them. But that in itself doesn't explain the entirety. And that leads us to that framework that we've referenced before about understanding access through the various dimensions that play out. And the other way of looking at that then is how that plays into driving behaviours. As we know, COM-B, capability, motivation, opportunity are the three factors that play into and can predict behaviours. And it's helpful for us to look at this because there is a danger always that we assume that a campaign or a different poster or a different way of conveying the message in itself is enough. I'm not saying here that that isn't a part of the element, and certainly the work that the team has been doing, you'll see on the left-hand side what elements broadly are the factors that are playing out from a capability perspective for our population. Some of that is about the capability of being able to get to an appointment. It is about understanding what vaccines are about, having that literacy level. So there is a capability element for some sections of our population. From a capability perspective for us as an organisation, some of the challenges that we face are, it is very difficult to have one version of the truth that is accurate at that one point in time, because there are different mechanisms and different contractual elements about when different providers provide us with the update of who they vaccinated, where they vaccinated. And so we have a mixed economy in terms of being able to really understand that. And each of the schemes run on different systems. And so whilst this is recognised nationally, and there's work going on nationally to try and create a more streamlined system that helps us understand in real time where our risks lie in terms of who's vaccinated and who isn't, that isn't something that's coming into play in the short term. And why is that important? Not only because we want to know here, but it is also because we want to know in order to be able to drive our activity accordingly. And that, therefore, we are hampered to a certain degree. But there are significant inroads being made this year in the way that we're working. If we then look at opportunity, so opportunity from an individual perspective, we know from some of the work that the team is doing that poor transportation links is making that difficult for some populations. Also, elements such as the opening time. So if somebody's relying on their GP surgery, but they're only being offered those 9 to 5 for the most part, then that makes it difficult for people who are working. That's a very practical example that we could probably all relate to, and it's the reality of therefore how do we overcome that, and it's by knowing who is having those problems, the team are then able to mobilise the ambulance, they're able to go out to those areas. So we have a way of doing that, but we need the information and the feedback loop in real time. From an opportunity perspective, from an organisational, from us as a health board perspective, we've had a shorter window for delivery for some of these. They started in October rather than September. Things like having a reduction in peer vaccinators impacts how easily we can respond. And from a motivation then, again, I've tried to draw those out so that we've got a clear understanding of from our client group's perspective, elements to do with hesitancy and reluctance. We've got more and more vaccination programs coming online. RSV is one of the newer ones. And there is a sense of, if they're not seeing this as a condition that's rife in our community, then where's the motivation? If we're not seeing mumps and measles, if we're not seeing things, then actually it's probably something I can not worry too much about. So those are some of the things that are coming through from the insights that we're gathering. And from our perspective, in terms of the motivation of our provider landscape, it's complex. It's not a case of saying that people are or are not prioritising this, but it's the reasons why it can be difficult to deliver when you've got, this is one of several things that these providers are trying to manage day to day. So the actions that we've articulated here are addressing those elements. And broadly, in the short term, what lived experience is really important, that insight. So the makeup of the vaccine equity group includes underrepresented sectors of the population that we know we need to target, third sector providers, GPs. It's really been revamped this year, and that is working really well now to be able to work in real time and adapt and adopt new practice. And recognising that then feeds into the targeted and tailored provision requirements, and being able to act on that very swiftly, because it's a matter, there is time pressure in terms of trying to get these vaccination schedules in place to have maximum protection for the population, but also needing to improve the way that we communicate a message, different languages and different ways of communicating. But also recognising ourselves as a messenger. The NHS is a really important, trusted messenger, so we all play a role in that. And then the medium to long term is really about learning from this year and building that in real time to think, we've got a mixed provider landscape. Do we use our providers in different ways? Should we be thinking about how we use community pharmacies different from our GP practices? So there's some of that work to be done, and I think the work group that's been established is getting into that space of understanding how do we make this more effective with what we have, and shared learning across health boards. Some health boards are doing better than we are, and we need to understand why is that, and is that something we can adopt here? So there is that also coming into play. And there's another one, often, as I referenced at the very start, one of the streams are about those who've got long-term conditions, because they're often at increased risk. And they are often the rates that are lowest across the board, not just for us and Swansea Bay, but across all health boards. And I guess the question we then need to ask is there more that we need to proactively do from the services that they will therefore be in contact with, whether that's our diabetes service, whether it's our cardiovascular service. So I think there is more that we need to be doing in that space in order to do that. And so what the board is asked to do is to note those actions and what's driving the differential uptake, and to support the progress that we're intending to do along the actions that we've just outlined.
Thank you, Dan. I'm just going to ask Richard to come in before I open it up for one or two questions. Richard, over to you.
Thank you. As you said, Chair, vaccination is one of those things that we can do to protect our communities. And what's of concern in here is, as you said, Jennifer, is that some of the lowest areas of uptake are our most deprived communities. And it's in those most deprived communities that the individuals who are most vulnerable to the diseases we're trying to vaccinate against. And while we can appreciate that, we can, what you've described then is that targeted approach, which is key to this, isn't it, in terms of understanding the reasons why people might not choose to have the vaccine versus the reasons why we may need to modify our programme to accommodate those individuals' lives to make it more accessible to them to attend. And I think just having clinics in which we offer the vaccine isn't enough in those communities. It's what we do and how we have a more nuanced approach and targeted approach to those the most vulnerable areas of our population.
Thank you, Richard. Nicola, you wanted to come in, and then Anne-Louise.
Hi, thank you, Jen, for that's really informative. Yeah, just wanted to touch a little bit more on the MMR. Obviously, the families have committed because there's quite large numbers for the second year vaccination and the numbers have dropped for the year 4. Just wondering what we're doing around comms, how we are publicising and promoting. Are we working with local authorities? Is there a way of maybe doing like short videos that are going to be spread on social media? If there's a video that was able to sort of advertise the importance of MMR, because I know a couple of years ago we had a massive outbreak and you had huge numbers of people came in to have vaccinations outside Morrison Hospital at one point. If there was like a short video that could actually be shared with schools and that could be shared on a text system, going out to families just as a bit of a reminder. Not sure if there's any work on that we could do in.
Yeah. Yeah, there is work, and some of this is happening nationally as well, so that's being used to draw in, and then it's going into where we've got the differential clusters, because there is a difference, and it's the difference that we also want to try and understand. So why is it working well in some areas and not others? And some of that is the way it's provided. In some areas it's more you get a letter but no further follow-up, but I think what you'll also see with those figures and how they shift as a child gets older is that once they get into school, they're more of a captive audience as well. And often that means that it's easier to be able to offer it there and then for them. But it's in those early years that is part of the element. And, we're hearing elements like, well, that we're back at work and we can't get to where it's currently being offered. So it's not all just about wanting to promote it, but where there is a need to get the message out there, that is being done by the team and using some of the national work, but enhancing that also locally. And I believe that Richard maybe wanted to come in on that as well. So, Richard, do you want to come back? Richard Thomas, sorry, he's online.
Richard, are you there?
Yes, I am. Yes, thank you, Chair. Yeah, just to build on what Jen was saying there. So immunisation and vaccination is a priority for us in terms of campaigns going forwards, and it already has been as well. So it is an important message to convey. I think some of the challenges that Jen's touched upon are around apathy, but also around misinformation as well. So again, I'm glad that Jen has referred there to the national sort of agenda, because I think that's the best place for those issues in terms of misinformation, particularly on social media, to be addressed, because I think that's a growing challenge for us. I think our focus is very much on the availability, but also on ensuring that we promote instances where people like me, in effect, are actually getting the vaccinations and the immunisation done, so that people can see people in their communities who are like them, who have gone through this and done this, and actually are their role models for others. So that's the focus in terms of how we promote this particular agenda. But it is really, really important that we do it that way, but also work with the grain of what happens nationally in terms of tackling the misinformation out there.
Thank you. Is that helpful, Nicola? Thank you. Anne-Louise.
Thanks. I'm going to sound like a stuck record because I note that in Jennifer's report under opportunities, one of the issues is a reduction in the number of peer vaccinators. And clearly in the proposals, the short-term immediate proposals, is to make sure that there are staff in the correct places to be able to provide the vaccinations where people are, rather than where we would like them to be, because they need to come to us. But if there are too few vaccinators and no money, how are we going to tackle that particular problem?
Thank you, Anne-Louise. I'm going to ask Sarah to respond to that as part of you coming in on your items.
Yeah, no, absolutely. And actually that plays out in the evidence in terms of our staff uptake. So we have a more significant uptake in our site acute site areas than we do, for example, in more of our community-based services such as mental health. So currently at 16% in mental health, so Nisbet Talbot Service Group at 30% as a comparison, so that absolutely plays out. I think it's about how we motivate and engage those points that actually Jennifer raises in terms of that can't be. It's about going to the hearts and minds of our staff in terms of getting them to engage with this as being a priority for them. Actually, I'll pick up my point, Chair, if that's okay, in terms of where I wanted to come in. Particularly reflecting on that, we're seeing that response play out with our staff as well in terms of themes that we're seeing in terms of their own take-up of vaccination, and that will lead to their decisions as to whether they will engage with us as peer vaccinators as well, so working to their goodwill. So some of the themes we're seeing from our staff in terms of take-up are around personal beliefs, views of influence in others. So that ability within an acute site area, you've got the ability to encourage your teams to do it. Certainly evidence from leadership becomes incredibly important in this space in terms of encouraging those to take the vaccination themselves, but equally then to step into the space of vaccination. What we can't do is create more roles, Anne-Louise, in terms of answering the core of your programme, your question. What we need to do is engage with our staff in a different way to encourage them to come on board with us in terms of supporting and helping that. And that's about understanding those issues in order to do so.
So do I understand from what you've just said is that the number of peer vaccinators has dropped off as this information about vaccinations themselves spreads, including around staff, that they are disinclined to vaccinate because they don't believe in vaccination? Or is it that there are just fewer people coming forward because it's not part of their role and they don't want to add to it? Don't really understand why there's been a drop-off of peer vaccinators, because lots of people, as I understand it, stepped forward to offer jabs during COVID.
Yeah, no, I wouldn't link those two elements together. That isn't the theme that we're getting back. So those elements are not can be uncoupled. It's unclear, but it's not. I think the issue with peer vaccinators, there was, as you say, there was a call to action through COVID, and I think that is now waning also, and business as usual is crowded in. I think one route around it potentially that we could look at in order to address how do we therefore match our delivery model with what the resource that we have would be more of a fixed base. That was one of the things that the team said would be really helpful, somewhere where we get regular footfall of staff coming through in and out, and therefore you can manage it, you can manage the workload with fewer vaccinators, but that's obviously because of the nature of our buildings and how busy our sites are and how much we're trying to cram into it. That's always sort of been a bit of a challenge, but that would be a solution. But those two are not, in my understanding, they're not coupled in terms of it's not a belief element that is driving people not to be coming forward as peer vaccinators.
I think we could discuss this forever, really, because it's such an important issue. Rena, I'm going to suggest that the Workforce and OD Committee has a look at all the aspects around staff uptake and the points that Anne-Louise has been making there. And that, Steve, we remit to population health the wider agenda around vaccine equity. Is that okay with everyone? Because clearly this is really important and it's going to be ongoing business for the board. Is that okay? And Jen, thanks ever so much, because I know there's an awful lot of material underpinning your presentation there. And Matt, perhaps outside the board, we'll take a look at the whole question of data sets in this whole arena. Is that okay? Thank you. So we're moving now into a new section of the board meeting, and we're moving into in-year delivery, quality, safety, and the oversight the board has over performance and resources. And this is where we really start to bring in the work of our committees. And we're going to start by asking Pat Price, Chair of Performance and Finance, to really advise the board, as I said earlier, with a 3A approach on all matters from performance and finance. Pat, over to you.
Thanks, Jan. Obviously, the two reports from September and October are part of the papers. So I was just going to, I'm going to go through those, just going to look at the alerts within them. Obviously, the biggest concern for the committee is the financial position. This is highlighted in the October 3A's report. And in October, we had a report on Morriston Service Group on their financial performance. And it is looking very likely that their outturn position will be above their control total. They were looking at the time at about circa 20 million deficit compared to a control total of 15.6 million. And that was due to service pressures, related variable pay spend and high delivery risk on savings, both in year and recurrent. Ongoing service pressures, we've seen these all through the year, resulted in the committee putting an action in place on the need to test the service group's base budget using benchmark data from Wales and England to ensure it kind of reasonably reflected activity levels and acuity levels. And then this month, we received a report from Neath Talbot Singleton, where again there were concerns about the delivery of the control total. Theirs is 11.8 million, and the outturn position that Kerry noted was looking more like 14.5 million. The service group continues to look at mitigation for that. Most of their overspend in year was on surgery, and that wasn't due to increased activity in relation to planned care or the new theatres, both of which were fully funded. It was more related to the historic baseline activity that was based on 1920 levels and is underfunded. Again, that raised the need to benchmark and look at base budgets again. So overall, the risk in relation to the Health Board's financial position increases month on month. Again, this was in the October report, but the issues raised in the meeting that we had on Tuesday, variable pay savings against the 25% target had not been realised. Month 7 being the highest spend to date at 5.8 million. The savings target, 59 million. The estimate was that 47.8 million was deliverable. But finance are not seeing that level of savings coming through on the ledgers, which is indicating that the level of risk could be greater than that figure in terms of hitting the 50.1. The committee looked at the Recovery and Sustainability Board. We were very pleased with the membership. We were really pleased that you were chairing it, Abby, because it gave it that cross-organisational lead. We were concerned about its ability to ramp up with the required pace and impact on cultural change across the Health Board, because it's going to be a huge cultural change programme. They were concerned about resource levels to support the board, both whether we were refocusing existing resources effectively and new resources that might need to put that change in place. The committee are having a report on the RSB coming through next month, and that will cover off governance, actions and impact support, and the proposed resource bid that Darren and Brian are looking at to Welsh Government. We are having a mid-month meeting starting next Tuesday that's been scheduled, so we're having an update meeting in between finance committees, and we're aware of the special board that's coming up on the 19th. So the risk around the delivery of the 59 million savings remains very high, both in year and recurrently, and the committee has a low level of assurance that the 50.1 million deficit will be achieved. So we would like to see the list of one-off savings that we need to bridge that gap, hopefully coming through on the 19th. So that covers off the finance. There were other alert areas in relation to performance and TI, UEC, of course, urgent emergency care, and in particular, a lot of conversation about the level of clinically optimised, 254 in October, with 134 in Morriston. We were aware of the work that Deb's doing nationally and regionally on this, but it just doesn't seem to get the traction needed. So, something needs to be done urgently, nationally, really, isn't it? Regionally or nationally. And that's having a knock-on effect, both in terms of stroke and neck and fever, the ring-fence beds there, and it's affecting performance on both of those. We haven't really seen any improvement over the last 12 months. NDD was raised at 31%. But 700k of non-recurrent funding is coming through, which may help address that backlog. And the last one was health-acquired infections, which obviously Steve will cover off on his quality and safety report. So those are the areas from this month's mainly.
Thank you, Pat. And can I place on record my thanks to you and the members of the Performance and Finance Committee for the rigour with which you exercise your oversight role. And of course, we will place on record all your alerts to the full board, and the points and the alerts are well made. And Dan will pick them up, I'm sure, as we move into the finance report, and then Deb will pick up as we move into performance. Can I just ask, before we move into point 7, is there anything else that anyone wants to add or comment on in relation to past update on performance and finance, please? Thank you. So, as I say, we'll place that on the record because those are important alerts, and the board takes full cognizance of them. Darren, shall we move into point 7 at that point?
Yes, thank you, Chair. So the paper before the board is the routine financial report to the board, which covers revenue, capital, cash and public sector, payment policy. Given the discussion, I'm going to focus mainly on the revenue position and just to note an important piece of the cash management for the health of the Chair. Thank you. And firstly, take the opportunity to reinforce the message you made at the start of the discussion of the board today, which is we don't have any formal authority to go ahead and forecast at the year end. All of the conversation that we'll have ensuing this is very much related to that diligent focus that we have. As the Chief Executive mentioned, since the last board meeting, we formally escalated the finance planning strategies target intervention, and we are concluding the process of looking at the level of support we would wish to receive, which comes with target intervention, and myself and the Chief Executive working through that, and that'll go up shortly. I'm also grateful to board members, as you extended your thanks to Pat for the discussion we were able to have on the 19th of November, where I took PFC members and yourself, Chair, through a very detailed account of the finances, and hopefully that was helpful in terms of understanding some of the states of the government. And to, again, support the message from Pat, and I agree entirely with Pat's assessment, the position is very challenging. There's still a significant risk in closing the gap from the 64 million interim position we had in our plan, 50 million, which is our obligation. The Recovery and Sustainability Board met on the 8th of November, and that meets again tomorrow. That's now in twice a month with them. And as Pat described, that will be followed then by a further scrutiny from the Performance and Finance Committee with an additional meeting each month as well to support. If we turn to the position itself, then month 5 of the report shows that the Health Board overspent by 3.1 million in month 7. Whilst that position is the best position to month and is positive, it was largely achieved by one-off means within the position, which was part of the plan, but of the things that we were going at from a finance perspective corporately. But the delegated spend, savings delivery is not where we need it to be. Again, Pat's highlighted variable pay and consumables particularly challenged. And that takes the overspend year to date to 47.95 million, and our original forecast remains that we will have to get to 50.1 million, which means we can only overspend by a further 2 million in the following 5 months. We've got a profile to look at that, which is based on the plan we submitted in September. The paper covers a lot more detail across pages 5 to 8, which I'll leave members to read, and those have been subject to scrutiny by the Performance and Finance Committee. But in terms of the risk that the plan is carrying at the moment, there's an £11.4 million shortfall in savings, and at the moment a £1.9 million assessment of costs, which are above the original projections made, which comes to 13.3 million, which broadly explains the gap between the 64 million and the 50 million. This is part of the revised rhythm then of the Recovery and Sustainability Board. Budget holders were unable to give assurance on their internal control totals, and that's highlighted 2 areas of concern whilst underneath the target singleton. At the meeting tomorrow, everybody who's away from their target control total has been asked to attend with mitigating actions to address any slippage on funding, and equally to address any controls around spend which may have been above plan. Specific challenges and board of Performance and Finance Committee that lead to me in terms of monitoring that, making sure we weren't just tracking savings, we were tracking spend as well. For clarity, we are now seeking to deliver £59.2 million of savings in year as part of the construct of that plan, which is 33 million more than the original plan. I think JP the report highlights that change. So we're not just tracking the old number, we're tracking the number which acts the plan. And further, and again, Pat touched on this, due to the level of risk within the overall position, I've been asked to make an assessment of further contingency that we could bring in alongside the plan to help assure delivery and reduce expenditure in the remainder of the year. That work is commenced. My finance business partner teams are working with service groups and some corporate directors at the moment. I'm expecting the first cut of that from a finance perspective by the end of this week. what would be important to contextualise that is the impact that those financial decisions will have in terms of potential service quality, patient experience, reputation, etc. And we'll do that diligently and bring that back to the board's consideration and information. The two main aspects of that then are that we will revisit the list of options we created to the Star Chambers in the summer. That exercise at that point in time identified £38 million worth of potential cost saving, cost reduction. We took 12 million of those 38 into the plan. We left 26 for further exploration for a variety of reasons in terms of either impact on service or they weren't ready yet and we could consider them in future years. Clearly we need to go back over those to look at the suitability to be proceeded within this financial year. It won't be 26 million because time has moved on, but we can go through that line by line and that's the work. In addition to that, with the Recovery and Sustainability Programme up and running, we're also looking at can we review investments that we've made as a health board, which is part of the discussion tomorrow, enhanced pay controls, picking up the point that variable pay remains still a challenge for us. And we've issued CHKS, which is a national benchmarking data set this week, because we've just had the 2023-24 comparative information across England and Wales, so that's helpful to test ourselves, not just within Wales, but outside of Wales. And that's a peer group comparison, and that shows opportunity. And the test for us is to really get into the granular detail of that, because some of those things actually don't translate into opportunities, but where there are opportunities that we take them and we accelerate that. And that tool has been issued to budget holders as soon as it was available. So that's the revenue position. From and I'm happy to take questions, I'm sure there'll be a lot more on that. From a capital perspective, we are forecasting now a balanced capital position. We've fixed our capital resource limit and reported that to Welsh Government, which they've accepted. We're also working very closely with Welsh Government at the moment to see whether there's any national slippage on capital. We have a list of priority areas that we can mobilise should there be potential for allocations to come in, should capital resource move around the Welsh system, which we do routinely this time of year with Welsh Government. From a cash perspective, there's a note and an appendix to the report where we need to formally submit our request for strategic cash. This is also something we do this time of year, particularly from the organisation in deficit. And what that will allow us to do is allow us to maintain a cash balance which is favourable and settle the payroll and the creditors in particular in March of this financial year. That is appended for board support. It's the governance group, so the board needs to approve that at the chairman, and that's their consideration as well. From a risk perspective, the revenue risk remains at 25. That's appropriate in my view, and we should change that yet. From a capital perspective, the risk is 20. I'll be reviewing that now in light of fixing the CRR, and we can reduce that risk in January and bring that through committee. So in summary, the revenue position is of great concern. There's a lot of good work going on. I wouldn't want the board to think that there wasn't industry around this, but clearly the scale and pace is not where we would want it to be. Some of the areas where we anticipated a change in practice have not borne the results that we would have expected through the plan, and therefore plans need to be accelerated and further enhanced. And I will bring back the further contingency work committee and board have asked me to do to a future meeting in December to give us an assessment of other things that we can bring to bear against the current profile of this.
Yeah, thank you, and thank you, Pat, for your perspective from the committee as well, and thank you, Dan, for running through that. So we are in a really difficult position, and when we had the JET conversation, as we touched upon at the beginning of the meeting, we heard very loud and clear the message from Welsh Government around the expectation that even the 50.8 is not where they want us to be, but they accept that's where we are. But there is absolutely no cover for us to go beyond that in any shape or form, and therefore the continued ramping up of the actions that we're taking is really important. And I think, Darren, in my mind, what you've described is a number of lines that we're taking. Yes, we've got to close the gap on the existing savings plan, and that is a really important part of the conversation at tomorrow's recovery and sustainability. We've also got to look at the spend that's going out in terms of the operational cost pressures and to look at how we bring those down, because there's no point getting the savings if we've got the cost pressures coming through. One of the things that you probably will have heard fed back, and again was a very clear message in the joint executive team accountability meeting, was around the view that we have invested money as an organisation that we didn't have to invest. And that is twofold. That is investment in development, and it is also about upping our baseline in terms of the allocations in some key areas. That is a large injection, I guess, in terms of our operational delivery. And we need to be quite forensic in going through what has that achieved, and has that been about making sure our services are safe and sustainable. But actually we need to test that for value for money and benchmark. We need to go through that forensically to look at where investments have been made, have they delivered what we expected them to in terms of operational outcome. Some of it's a bit too early to tell, and some of it we need to review, and we need to explore whether there are any opportunities of clawing that money back in year. We've talked about reviewing what was on the red list that the board, I know, took painful decisions about in terms of where our threshold for that was. We need to keep our services safe. We need to keep our patients and our staff safe. But we do have to go back around that loop in terms of the reds. And then we need to explore other opportunities, which means that where areas are already delivering and doing well, there's a very difficult ask, which is to ask them where they could go further. And again, there will be the obvious areas: procurement, prescribing, and any other non-recurrent opportunities that we've got to take in this year, so that we can come back to you on the 18th of December with greater assurance around what the final plan is in the last quarter. And for us, starting to shape what next year looks like, because it's not going to be any better next year in terms of our rhythm of needing to become sustainable moving forward. So beginning to get a flow into next year's plan in terms of reconfiguring services. So where we know that our mode of delivery is not the most optimal because we've got things on different sites or we've got teams crossing sites, we do have to have a look into that. And I know we can't make some of those changes overnight, but we've got to lean into that next year in terms of where those opportunities are. And there's a huge workforce piece. So the triangulation with the performance report, high sickness levels, we don't seem to be getting anywhere in terms of traction on things like absence rate. We need people in work, we need to support people in work, we need to be really supporting our staff. If you look at the reasons why people are out of work, we've got a bit of a chicken and egg, that people are off for stress and anxiety. That may not all be work related, but we've got to get in there in terms of our workforce model and reshaping the workforce to match the configuration of services. So we need to be bringing forward proposals for you to consider for next year, which is around how can we ensure that we're delivering more within the staffing capability and capacity we've got, and how do we help our service groups reshape where we need to the workforce to deliver within our financial envelope, which will be a continued journey, that one we need to really crack on with as we transition from the end of this year into next year.
I'm going to open it up for questions then. I've got Rena, Jean, then Helen, then Steve.
In one sense, Pat has covered a lot of the issues, and I do feel we are in a very good position, and obviously we are extremely concerned. The one that I was going to emphasise a little bit more is in relation to the COPs, which comes into the winter plan, because when you look at our numbers in terms of COPs, which we haven't really over the year or over the last few years seen much reduction in, it is costing us such a lot of money. And in terms of surge capacity, and it's also obviously causing all of the pressures that we know of within children care in terms of flow. So I do feel we're not getting to grips with those. And I think it's all about the relationship with the community sector and social services. And I know Deb is probably going to cover it off in the winter plan, but I really do think that going into next year, we need to get to grips with those numbers and to get those on a reducing trajectory, because frankly, it is at the source of a lot of our problems. Thanks.
Thanks, Rena, and I know Deb will pick that up as part of the 50-day challenge work. And thank you for the points you make there. Jean, please come in.
I guess I'm using an example just to raise the concern that we have about going into next year and building on your comments, Abby, about our preparedness for next year. If we look at the Cwmtach Morgannwg experience and the cost that we're incurring, what I'm concerned about is where we are undertaking an action that we are obliged to from Welsh Government's dictation. Do we really understand when we're budget setting at the beginning of the year what that impact is going to look like on us? And I'm just concerned because when I read about the clinical consumables overspend, for instance, do we also have the granularity of detail that says, if we're managing, for instance, the Princess of Wales patients coming into us, we would not necessarily have had prior notice of that, and we would not necessarily understand what the number of patients coming into us would look like. So that's all an on cost. So my purpose in mentioning that is to come to Matt and say, in terms of our digital experience, are we sure that we have the right systems in place to make sure that we can inform Darren as best we can what our current spend is, what we could be saving on, and what our budget setting for next year should take into account from this year. Because what I'm concerned about is we quite rightly are really concerned about meeting our 50.1, and we have to meet that. What I am concerned about, though, is that we are focusing so much on the operational element that we will lose the opportunity to forecast what our real budget should look like for next year, but also not only internally, to also consider the external focus that is brought into us that we don't necessarily have notice of when we are budget setting. So that's a very protracted way of saying, can we please make sure that we are undertaking through the systems, Matt, the granularity of detail that will inform Darren and the other cost centre managers next year, but also to keep a lens not only internally, but what external influences might be on the horizon as well.
Dan, do you want to come back on that point before I bring Helen in?
Yeah, I think it's a very valid point, and perhaps a point that doesn't always become very visible to the board chair, so we need to reflect perhaps on how we report these. So we have mechanisms called long-term agreements, which are the contractual arrangements between health boards across boundaries, and we commission from others, and others commission from us. So it's a complex beast, Jean. Those are set historically and were frozen through COVID, so they do a refresh. They're not particularly fit for purpose at the moment, but we do know when a resident of another health board, not just come down from Uganda, but any other health board, arrives in our services, and that process picks up that activity. And there's a financial return for that activity. The challenge in terms of the future proofing of this is does that financial return now represent the cost of Swansea Bay of providing that 1, 2, 3, 400, 500 extra aspects of care, whether that's an urgent emergency care medical admission that flows down the motor in an ambulance, whether it's a trauma patient, or whether we're picking up more elective cases as well. So there's a financial mechanism to do it. It's supported by the patient care data set, to quote something technical. But the financial return in that needs to be refreshed to make sure that we're recovering costs in the right way. And then when that income arrives in the health board, we distribute that into our service groups as well. Because that's more of a sort of corporate exercise. So it's a budget set appropriately to recognise that in that, and then it's a lot easier to manage. So it's a fair challenge. The architecture is there, the accuracy goes
So that's clearly more work to do around that. Abby, do you want to come back in?
Yeah, two comments. That piece of work around what it actually costs to deliver our service and the history of the separation from and the reconfiguration of the CTM boundaries. I guess there may still be some legacy issues. I know we've got a meeting with CTM next week, but I guess there may be some legacy issues. I guess what we need to look at is being really clear that we understand the cost base of our services, being really clear where we benchmark. If they're higher than a benchmark, are we clear why? Is it a critical mass issue? Is it a safety issue that we're having to pay more because we've not been able to recruit or retain or attract, or we're outsourcing and relying on non-core activity to fund some of what we need to deliver? And Jean is absolutely getting underneath all of that, so we've got kind of really strong build-up of what our financial assessment is and what our plan is going forward. And I know Darren and the team have been doing an awful lot of work. And obviously we need to look at that in the context of our work with Hywel Dda, because they are running with a similar, slightly larger deficit than us and don't have a line of sight to get to financial balance, either in terms of the way that they configure and deliver services. So that will be a really important part of the work that we do jointly with Hywel Dda as part of the joint committee.
And Jean, I know it's an important point to make often around when you're budget setting, it isn't just about last year's plus uplift. It's got to be something much more radical for 25, 26. That point is well made. Helen, please come in.
Thanks. I'd just like to know, and I couldn't hear you, so I'm sorry. So what impact is it going to have on our public and our patients at Swansea Bay on your savings? Is there an impact on the savings you're trying to do for the public and patients of Swansea, Nath?
Right. So can you hear me okay? Sorry, I was probably just
Sorry.
talking about the room rather than down the room. So in terms of the current plan that we are working through, the impact assessments that we've done, the 12 million out of the 13 million we decided to move with, did not have that impact. There were serious choices that we made with it now. The ones that we are reviewing now, the next 26 million, which we decided not to do at that point, are likely to have impacts in terms of access to services and timeliness of access. And there are a wide range of things within that, which perhaps would be helpful if I took you through in perhaps a more detailed session just to show you what those look like.
Yeah, please, because obviously, you know, we would have concern if it is going to have a lot of impact on the residents of Talbot and Swansea. And if we could have that chat and how you're going to explain that to the public, the communication, you know.
Helen, we are having a single issue board meeting on the 19th of December. Just a single issue around what is going to happen for the rest of 24, 25 in terms of what do we have to stop, reduce, delay to reach our approved deficit level at the year end, and then what is that going to mean ready going into 25, 26. So, you know, you'll have that paper in good time to join us hopefully before that meeting.
Thank you.
Steve, do you want to come in now?
Yeah, thanks, Chair. So, a couple of things. First, I mean, generally, the paper is asking me to take assurance about a line of sight to 50.8 million. I'm not yet assured that there is that line of sight, and I haven't heard that in the room, that there's much assurance here. So, I don't think that recommendation carries. I was also going to say that, you know, we've heard in the in-committee section of this meeting that there are some other financial challenges coming along over the hill. So, you know, 50.8 or 50.1, whichever it is, isn't a low enough number. We need to get lower than that because we know that there's going to be other costs that aren't in your budgets at the moment. And the third thing I said, in the PFC, we've always been a little bit concerned about the strength of the team that the Recovery and Sustainability Director, Brian, has. And is that group strong enough and numerous enough to do the work that they need to do in the next several weeks?
So in the reverse order, Chair, we part of the ask for the support from Target Intervention is to bolster the RNS team. That will be a blend of further accountancy support. Actually, there's a lot of project management and analytical talent, and that's what we'll be asking for through that, and that's been worked out in detail. The point around recommendation, Steve, around assurance is a good challenge. We are clearly carrying a huge amount of risk. At the moment, I can't give board confidence that we are on trajectory to 50.1. And then your middle point then about risks emerging, there are a number of risks that we're aware of, risks we're trying to mitigate, but having something that takes us potentially beyond 50 million in the right direction would be very prudent, but we can assure ourselves on the sort of first wave of activity. There may be other opportunities that present themselves as well, but actively we need to pursue a level of contingency beyond 50 million to give us that confidence that we can actually get there.
Thank you.
Are there any other points? Dan, did you want to make any further points?
If there's no one else, I just wanted to pick up on the Chief Executive's challenge about future years and allocation. We will receive, so the Welsh Government budget is published on the 10th of December. We will then await the allocations from the Welsh Government sort of financial allocation process a week or so after that, and we're hoping to get that before the Finance Directors meeting and certainly a sight of that before our one-item board on the 9th. I think the important thing for us to do in the consideration of that, however the scale of that works, vis-a-vis wage award, national insurance changes nationally, is that we look to see how we allocate our money in terms of our population health requirements as well. Yes, we'll have cost pressures here, we'll have to manage, but actually we need to get ahead of the curve on things like diabetes, fibrillation, cardiac disease, and lots of other things. I think I'll make a commitment to the board to bring back some proposals, or some options, or some thoughts at least, on how we might start to change the way we use our money to get prevention on the agenda, as well as addressing some of those really wicked issues we're still dealing with in terms of immediate cost for us, just to make that remark.
Thank you very much, Darren. And we do know how hard you and the finance team colleagues are working. You're working day in, day out, every hour on this. We understand that. And we thank you for everything you're doing. This is an organisational-wide issue, and covers all directorates, all executive portfolios. So it's not on your shoulders, but we understand just how much you're doing in respect of this. So in terms of what the board needs to do, we are asked to take assurance, and Steve has clearly made the point. And from what Pat has said, with deliberations of the Performance and Finance Committee, there is only a low level of assurance we could take, because we have low confidence that we do have that line of sight to 51. So could we take a low level of confidence or no level of confidence?
No, mild optimism seems to, low assurance.
Knowing that, what's going to come on the 19th of December, I think we're talking about low levels of assurance.
Low level of assurance, because after the 19th of December, I have to go back to the Cabinet Secretary with a high level of assurance and confidence. Okay? So low level, so apologies, we can only take a low level of assurance that we have line of sight to our deficit.
Jan, in taking a higher level of assurance, though, there's going to be other implications that you're going to take alongside that, isn't it?
Absolutely. So that's why the 19th of December is absolutely crucial for, and it does assume that 50.1 million is the highest of all the non-negotiable imperatives. And before the 19th, I will be trying to determine that. So that is really, really important. So we are taking a low level of assurance at this point. And Darren, in respect to the cash forecast and the approval of the letter, Nuri has asked whether we think we can actually get to that point and that we don't want to call for it until March. So that we can get to the end of February before asking for strategic cash. Is that?
Yeah, absolutely. We've just to qualify that, we've made that assessment on the basis that organisations can manage their working capital as well in terms of credit repayment and debtors. So there are mitigations that we can make. So I'm confident in the assessment of the letter.
Thank you. So in terms of consideration of the balance sheet, we're hoping, expecting that on the 19th of December we'll come back with anything else that can help us from the balance sheet around that. And also, as Abby's indicated, we look to close the gap for the existing savings plan, and we absolutely need to sort of look at all the operational cost pressures between now and the end of March to make sure we can manage those and don't just take with one hand when we're incurring cost on the other. There is this sum that's bandied about of 40 million investment of monies we didn't have. So I'm not sure where that sum comes from and what validity it has. So for the 19th of December, when we're looking at investment, can we bottom out that figure, please? I mean, is it real? Sort of where did it come from? And as we've mentioned, developments, allocations, can we just be absolutely clear around that?
Yeah, we've started that. I know Brian's appreciated exactly some of that, but we'll get the definitive position for all that.
Thank you.
And I have seen the list from Brian, so I know what's on it, and it is specific investments in terms of service area pressures, and it is the increase in allocations as he explained it to me. But it would be very helpful for us to all understand what's on that list, so that we all kind of own it.
We all know what's on it, and we know what we can and cannot do about it. Yeah, that would be really helpful. And then, of course, we are going to come back to the red list as part of the 19th of December deliberations and any other opportunities that come to light through there. So is that everything we need to cover on the 19th of December? We'll also be looking at how we're going to look at sort of allocative efficiency then from 25-26 onwards.
Preliminary thoughts, yes.
Thank you. And then on the risk scores, has to stay at 25. Everybody happy with that? And Pat, thank you very much for the committee's agreement to meet sort of fortnightly. And if you could continue that frequency of meetings until the end of the financial year, that would be really helpful. Thank you very much. Okay, so we did take some time on that, and that was really important to do. So can we move then, Deb, to targeted intervention, please? And again, picking up the points that the Performance and Finance Committee made around performance matters. Thank you.
Thank you, Chair. Okay, so targeted intervention and paper is usual format. Board members will be aware the measures we were into targeted intervention for last month. We may then change their context, obviously with the addition of finance now as a new area of targeted intervention for us. So I'll cover off the main body of the report. I'll hand over to Hazel Powell for the healthcare acquired infection item, and then to Darren if there's any more he needs to add from a finance perspective. So the majority of the KPIs that we're being measured against remain stubbornly static and mostly positive, but some of them not considered going in the direction we want to with the momentum that we need. So I'll go through them individually. So cancer first, you'll be aware that our target for cancer performance for September was 60%. Unfortunately, that wasn't achieved. We achieved 57%. The balance of that is against where we are with our backlog removal, which we're doing better at, and what how that impacts on the overall delivery. I'm pleased to note the number of patients that did breach in September was fewer than previous months, but we treated fewer patients, hence the 57% rather than where we want to be on the 60%. Just a note on cancer performance, a quarterly review of cancer gets refreshed at the end of that quarter, and the last quarter saw us increasing in all of those 3 months, and we did achieve 60% in June as a result of that review. We anticipate that will happen the same way this year. So September's performance will be reviewed by the end of December, and we do anticipate that we'll see an uplift from that 57%. I've had a conversation with Welsh Government this morning because that's not actually reflected on an all Wales level and in Welsh Government. So they need to be able to access those uplifts because it is an actual change in the performance. So Martin Rees in Welsh Government is looking at that measure for us to make sure that that's reflected in national figures as well. But it is disappointing that we didn't get closer to that 60% in September. Plan care, that remains again our steadiest performance against the targeted intervention escalation criteria. It's steady. We do anticipate further improvement in November and getting closer to what we want to deliver at the end of March. I've had a conversation with Welsh Government colleagues on what next year looks like, just by way of information for planned care, and the target for overall RTT delivery is likely to be 95% of open pathways within 52 weeks next year. And for context, you can see there the third line in our table there shows we are at 84.77% at the moment against that criteria. Our targeted intervention criteria for that is 80%, which we're achieving. So if we do a bit of maths on what that means for us next year, our current number of open pathways is just below 90,000. So to deliver that 5% tolerance takes us to less than 5,000 patients, so for about 4,400 patients waiting less than 52 weeks. We've currently got circa 14,000 patients, so we've got to reduce that by 10,000 next year to achieve the next year's ministerial target. And we'll be doing the maths as to what that means for us and where we would want to use that tolerance going into 25-26. But we're certainly in the best position than any other health board in getting anywhere near to that. We were hoping it would be a 90% target, which would be inherently easier for us to deliver on, but it looks like it's going to be 95%. UEC, as we note, that remains a challenge for us. Most of the metrics are still improving, so the formal metrics that we measured against are still going in the right direction, with the exception of the pathway of care delays, which we've already mentioned here. I'll probably pick up more detail in the winter plan item, if that's okay, Chair, just to save some time and to not repeat myself in that one. All the other metrics are going in the right direction. We had a really tough weekend this weekend and come into a challenging position on Monday. But as the Chief Exec noted earlier, we did some real focused interventions Tuesday and Wednesday, and we are seeing the benefit of that. Fortuitously, that was in advance of HIW arriving yesterday evening, which was great.
It could have gone the other way, which would not have been so good for us. So we've really got to maintain the traction that we've put in the last couple of days and keep that focus on. Pivotal to that, though, are those pathway of care delays that we've got to get underneath. Just important to note before I move on, the metric and how we measure pathway of care delays is changing. And what that was, so in all of our numbers at the moment also include patients who are classified as a delayed clinical transfer, which means they need to move, for example, from Morriston Hospital to Neath Port Talbot Hospital. Morriston are currently recording those as a pathway of care delay, because for Morriston they are, but in the true definition, the new definition, they won't be included as pathway of care delays because they're not a local authority issue for us. So we will see our numbers fluctuating somewhat. We'll include both though, so we'll include the totality of what we are trying to work through as a health board, but we'll explicit on what's a pathway of care delay with the new criteria and what's an internal delayed clinical transfer between our hospital sites. So the overall number you'll recognise, but we'll dig down into that, and that's an important one for us to make sure we've got credibility with local authority colleagues is where we need them to focus their efforts. CAMS, moving on to CAMS, positive delivery in CAMS, so we're now delivering again on all of the CAMS measures, which is a positive. And on that note, I'll hand over to Hazel on the IPC issues.
IPC, thanks Dave. So the improvement we saw in September has not been maintained into October, but we are seeing some improvement into November. It's a fluctuating picture month to month, which is disappointing, and our biggest concern is C. diff. In terms of outbreaks and clusters of infection, there were 16 outbreaks that resulted in beds out of use, and COVID is still the main causative agent. However, we saw an increase in other respiratory viruses as well, so influenza and RSV, with influenza implicated in bed losses on 3 wards during October. Reliance on natural ventilation and ageing buildings continues to be a challenge, with no national capital programme aimed at improving air changes in NHS hospitals. To mitigate the impact of COVID by transferring COVID recovered patients to maintain available beds for emergency admissions. In terms of the actions to improve, maintain our gold C. diff high incident management group, that continues with silver groups reporting into gold. The digital intelligence development team and the IPC team have commenced work developing an application that will facilitate the monitoring and analysis of hospital-acquired infection case reviews, which are really helpful in looking at decision-making and influencing next actions. We continue to work to do some work looking at C. diff risk stratification, so identifying the people most at risk of C. diff when they come into hospital, and using that to really inform our antibiotic usage and review of PPIs. And we're doing a scoping exercise with the digital team aimed to improve the GP discharge summaries, again highlighting risk factors for C. diff, so that again that PPI usage could be continually reviewed into primary care, back into primary care. The clinical teams in Morriston continue to roll out the newly developed prescribe and audit tool for hospital-acquired pneumonia, and cross-health board IPC discussions are underway to identify the key issues in learning. And we're reviewing the evidence for and scoping with other organisations the risk-benefit associated with the creation of a C. diff cohort board. There'll be a paper comes to management board in January that will help us look at the ongoing work around HPV, decant, and also explore where we get to in terms of recommending cohort warding. That's all I want to say, Dave.
And then to Darren, if there's anything further to add, Darren, from a finance perspective.
I believe colleagues would agree that we covered that off.
That's the TI update, Chair. Thank you.
Thank you very much for that. That was really comprehensive as always. I'm just going to ask now, going through the sections of the report, anything that anyone wants to pick up on the cancer update on that? Planned care? Anything on that? No? I think the actions were particularly comprehensive there. Urgent and emergency care, which of course we will be linking with the winter plan. Anything now that you want Deb to think about to come back on winter plan? No. And then we've also had an update from Hazel as well on HCAI and CAMS first, which is good news really, so that's really important to take note of as well. HCAI, anything there's comprehensive work programme, and of course we're coming up to very difficult months now for rates of HCAI. So we're asked to consider everything that's underway, Debbie, and there are a number of actions being taken, and clearly you do keep us up to date on everything that's happening there. We'd like to thank everyone for the work that they're doing in this respect.
Chair.
Thank you. So Darren, do we come back to you then?
Yes, thank you, Chair, and I can possibly give us a bit of time back, because obviously lots of the performance report relates to
And
targeted
what I
intervention.
do think as well, even though we're scheduled to run to 1, after we've done the winter plan, shall we have a 15-minute coffee break? It's been heavy work this morning, okay? So, thank you. So, Darren.
Incentive to be brisk. Thank you, Chair. So this report has been through Performance Finance Committee and had scrutiny there. Appended to this report at the half-year mark are a number of the qualitative returns that we make as an organisation of Welsh Government, just for board information, Chair, knows going to the organisation. I'm going to start us then at page 24, which is after all of the target intervention sections, and just draw on some aspects that aren't in the TI. So ambulance red releases within 8 minutes. This is subject to some debate in the media today, this target. It went up to 51.5% in October, it's 47.5% to date, which is a little short of the 65% the target required. Then on to page 27, where we report the 4-hour ED target, which is the most traditional one. It's not part of our TI measures actually, but just keep an eye on this because it's a good metric. We were at 78.7% in September, 75.7% in October, 72.8% today, but that would be an unvalidated position, so expect a couple of percentage points additional. I'll then move us on quite quickly through the report, and just turn the page to pick up access to therapy services on page 39. That is in as a percentage under the target intervention, but just to highlight there are pressures in podiatry access at the moment at 14 weeks, 143 patients waiting longer than that. We're working with the primary community therapy services team to resolve that, and we believe that will recover certainly by the year end, if not sooner. That's the challenge for them, to sort of highlight that. And a couple of pages on cancer which follow. Adult mental health access is on page 44, and the first 3 measures there regarding assessments, therapeutic intervention and care and treatment planning remains high performing for us. We have significant challenges in terms of access to psychological therapy, largely related to increases in demand. I think it's a national phenomenon, but we are again working with the mental health team to address that and look at what the solutions to that may be. Let's just take us on to page 50 of the report. As a matter of accuracy, we'd reported 2 NEBRA events when the report was drafted. One of those has subsequently been classified as not an NEBRA event, so there's an accuracy point there. And the other one is being worked through as an NEBRA event. It was a retained swab after throat surgery for patients. Page 52, just to pick out sickness rates, that was 7% in the most recently reported month. On that page, you can see a distribution of the reasons for that, which I mentioned briefly on the way through. And the final thing I was just going to bring the board's attention to in terms of the performance report was page 54, and friends and family surveys we mentioned earlier in the board meeting. It's critically important to understand the experience that patients are having, and during October we carried out 6,208 surveys, which is the most in the reporting period here, with a 93% satisfaction rate, which I think is an important context in terms of the challenges we're facing collectively. I'll stop there.
Take a breath now. Thank you, Darren. That was very, very succinct and took us through all the key points there. So can I ask please any points of comment, question for Darren? Anne-Louise.
Just to ask about the falls, because having made some significant progress at reduction in falls, they've gone up again, and I just wondered whether there was any indication of why that should be.
So the team are currently looking at that to try and understand it. So I would want to come back with some more detailed information rather than try and answer that today. We are seeing some marked improvement in some of our community areas and our conveyance to hospital and falls in care homes. The blip in terms of inpatient falls we're trying to get underneath. So if I could come back to you on that one rather than
Just on that, and Hazel, guided by you. It's one of those areas where I guess if it's getting under the detail about are they injurious falls, because clearly getting people up and out of bed and moving, we have a greater risk of falls. It's about actually are we managing them and people are not coming to harm. So it's getting underneath that a little bit, isn't it? In terms of which we want people to getting up and out of bed.
Yeah, which is why I wouldn't want to give too much detail today, just so that I can be accurate in terms of giving some assurance.
Thank you. So Hazel, can we send a briefing note round outside the board, please? So we don't wait for the the next board meeting on that. Thank you. Keith? please
Yeah,
go ahead.
thank you very much for the very comprehensive report. I just wanted to pick up on page 45 about CAMS. In there's a statistic on the wait for neurodevelopmental disorder services, which shows that we've still got some work to do there. That didn't feature in the previous paper where we looked at the CAMS service. Is the wait for neurodevelopmental disorder services not included in the other report? But even if it isn't, then the wait is still concerning.
Yes.
I'm not sure about that.
Dan to clarify that.
Yeah, thanks, Keith. No, it's not included. So the CAMS service is separate from the ND service. So CAMS sits in mental health, ND sits in paediatrics, so they are very separate services. I agree. Perhaps we need a bit more visibility. We're not under TI for ND at the moment because ND is known to be a national constraint. We have received some additional funding from Welsh Government recently, though, to address some of our ND long waits, and the team are working on the plan now to reduce that.
The reason I raise that is that when many people graduate from paediatrics or CAMS, their assessment for neurodevelopmental disorders, some goes to the Western Bay Integrated Autism Service, but a large number go into adult mental health services.
I think that is an important point, Keith, and also in terms of how we pull this whole thing together. So Abby, I know you've got some thoughts on how we might change the approach to reporting. Do you want to talk us through that?
We had a meeting with them, didn't you?
Yeah, I mean, we had, on the specific issue, we did have a really useful visit from the Minister, Sarah Murphy, and we were talking to both adults and children and young people's neurodiversity services, and there's definitely some work to be done around the different approaches we've got in children and young people's services and adults and how we can improve that. So keep that as a piece of work that is live and we need to look at. I was going to make a more general point that I am, coming into the health board, really impressed with the amount of data and performance information we have got. This is a really rich and performance report. I guess there's an observation that we repeat it because we're coming at it from different angles and different items. And I'll take away with the team, is there anything we can do so that we haven't got kind of finance covered in 3 different items? But I know that from previous jobs, getting this right for a board at the board level is a tricky thing to do. So we will take our time to step through that, but we'll have a look at how we can perhaps streamline some of the reporting so that we're not repeating in quite the same way. We are required to report it slightly differently in different places. So what we're doing is giving you the comprehensive overview of all of those reporting mechanisms. But a conversation we'll pick up with the team is can we streamline any of that as part of that discussion going forward?
Thank you. But we'll pick up your specific point, Keith, as well, and come up with an action.
The only reason I mentioned it is because it features under the CAMS data in the performance report.
Yeah.
And from a patient or parent point of view, it doesn't really matter which service your condition falls under, it's whether the right to get a service.
Absolutely. Thank you. And I think that I'm sure we're going to want to go back to Welsh Government on the fact that the money they've allocated is non-recurrent. And we absolutely need some recurrent funding into the service, so we will be coming back to that. So thank you very much for that, Darren. So we acknowledge and we've discussed really the board's overall performance issues. We've got some specific actions which Claire will report, and then obviously Abby and the team will be looking at the presentation of all the performance and finance data as we come back in January, and then we'll be refining it in the months to come. Thank you. So, Deb, shall we turn to you again then, please, for the winter plan?
Okay, thank you, Chair. I'll try and keep my bit a bit brief and leave plenty of time for debate, which I'm sure there will be plenty of. Okay, so the paper sets out where we are currently. So you'll be aware that we had to do a submission against the 50-day challenge, which was the Cabinet Secretary's priority going in ahead of winter, and alongside that we also are requested to submit a regional partnership board winter plan, which we have to submit into Welsh Government tomorrow. So what we've tried to do is dovetail both of those. So what we've put into the 50-day challenge submission is intricately linked to the solutions we put into the winter plan. And the challenge in both of those at the moment is any financial resource that's going to come to achieve both of those. Now, obviously from the 50-day plan bit, we're already almost 4 weeks into the 50 days, so we've got about 22 days left of that 50-day challenge, and some of those actions won't be confirmed yet because they are included in our winter plan. So just for context, that's the difference between the two of those. So as I said, the winter plan submission is a joint piece of work between the Health Board and the two local authorities, coordinated through the RPB lens, supported by our planning team within the Health Board to make sure we feature largely in that. The PowerPoint presentation that you'll see gives the details of what's in that and our priorities, particularly in the prevention space, how we bolster our business as usual services across the region, and then a few slides on where our priorities are for what we could do more if resource was available for us to do that. Within the paper itself, rather than the PowerPoint presentation, then we outline where we are for options that we need the board to consider today. And they are 4 options. Option 1 is aligned to our financial plan, and board members will be aware that currently our financial plan makes the assumption that the expenditure that we've got in our surge areas goes away. And that is 30 beds that we've currently got open at Singleton and 15 additional beds that we currently have open in Gosainen. Those numbers have changed slightly due to the pressures we've had, and we've surged further into those areas. Plus we've got surge areas open within Morriston and Leith that we are managing at risk from both a staffing and a funding perspective. So that's a risk for us when we're trying to dovetail this with our financial plan alongside that. So option 2 is the do nothing option, that we keep that surge capacity open from a health perspective, and obviously we would need to absorb the cost of that within the rest of what our financial plan is going to develop into by the end of the year to make sure the financial risk is managed in that context. Option 3 assumes we're going to do option 2 and keep those surge beds open, but in addition utilise this 500k of RIF slippage available to us that could provide us some additional capacity either within the health environment or within local authority services to get us closer to releasing some of the capacity that we need for winter. And then option 4, which would obviously be our preferred option, is utilising any additional funding that we get from Welsh Government to support the additional schemes that we've got in place. Now, those additional schemes at the moment have a circa £4 million cost against them all. What we're doing in advance of any news coming forward from Welsh Government is prioritising all of those options by way of what could we do quickly and what would give us the biggest benefit for that investment over the winter period. Now, that's going to take a little bit of work to be done, which is why it's not been done as yet, because we don't know what the money is going to look like. And because of this, as John noticed earlier on, the short-term funding that we're likely to get, any additionality we put in will be likely to be asking our existing staff in both health, local authority and private domiciliary care market to do extra for us for additional funding, rather than any recruitment schemes, because we won't have the time to recruit into and the money is non-recurrent. So once we know if there's any money and what that envelope looks like, we will then work those up at pace to work through. The team's already doing it in the background, so we're ahead of the game, but I haven't got the detail on that to share with you today. So what can we do quickly and what's going to give us the biggest benefit? We think an announcement's going to be made on the 3rd of December, so next week. And what we do know is that any funding allocated will be to the Regional Partnership Board rather than into either health or local authority. So it remains a really partnership piece of work that we need to do over winter. From a prioritisation perspective, we have agreement from ourselves and local authority that the schemes we want to prioritise will be those that promote further discharges and further admission avoidance to manage patients and the population as well as we can at home and with limited conveyances into hospital where we can manage them safely, and then exponential discharge from hospital back into those services. So I'll stop there, Chair, and take any comments, and I'm sure we'll get into a broader conversation of our UEC pressures as a result of that.
Thank you, Deb. And again, an awful lot of work has gone into this, as we know, and we're grateful to everybody for pulling all this together. So can I ask for comments, questions? Pat?
Thanks. And just in terms of the options, I mean, our current plan assumes then that those beds for 24-25 assumes those beds in Gosainen and Singleton shut.
The financial plan does yet. The operational plan is struggling with that concept, obviously.
Yeah, but it isn't almost, I mean, you would think then you'd say, no, closed because we don't have the option, but there's a massive opportunity cost to shutting them in terms of then you end up with those people sitting in high acuity wards in Morriston, because I assume the surge beds don't come under the Nurse Staffing Act.
They don't, but they're still staffed as a hospital ward where the patients don't need hospital care. So they're still overstaffed by way of a context of what we would be, what those patients would have if they were not in a hospital environment.
Yeah, higher proportion of healthcare support.
So they've still got medical input, for example, whereas if they weren't in a hospital, they would not have medical input in that way.
So that's quite a difficult thing, isn't it? Because it's a massive opportunity cost to that one.
And just for context on that, Pat, it's important to note that obviously the wards that these patients are in are not an ideal environment for them, which is why we need to staff it differently. So if they were in their own, bed-sit type area, it's much easier and they get a different support. But in an open ward, it is more challenging to manage that patient population.
On a similar thing, when you cost the surge beds, in your plans, when you're putting out the other, why do you exclude pharmacy and therapies from the costing? Surely they're critical in terms of the patient recovery.
They are, I suppose it's the same context, because they're clinically optimised patients, that should already be sorted for them. So if they weren't in a hospital bed, they wouldn't need that. The therapy one, absolutely, they do need to be in there, and the therapies are included in those plans. Pharmacy less so.
And finally, in terms of clinically optimised, is there anything, are our consultants in any way risk averse about discharging patients back into the community? Is that a factor in it?
I think we're probably more risk averse when it comes to admission. So I think that's where our biggest challenge in and how we manage these patients, and particularly those that arrive with more of a social need than an acute medical need, because the social need can't be addressed, and there's always going to be some clinical need with these patients because they don't fit nicely into a box, and it's only the social bit that they need. And because we can't provide all of that very easily for them, the decision to admit is the easiest option at the front door rather than to try and manage those. And that's the bit we really want to focus with our front door services, that there is an easy access to what the patient needs rather than it's easier to admit a patient into hospital. I think when it comes to discharge, there's a variation. So if we look at our geriatricians, they are not risk averse in any way. They will see the needs of the patient and manage them in that way. We get a lot of debate sometimes then between therapy colleagues, nursing colleagues and clinical colleagues and local authority colleagues as to what the best option is. That's where the complexity comes in. So one of our solutions in the winter plan is to roll out our IDH, the Integrated Discharge Hub, fully, so that we've got a team that are conjoined in their decision making and they manage the discharge as soon as that patient is clinically optimised.
Thanks, Sam. Thank you, Pat. I've got Rena, then Darren, then Anne-Louise.
I mean, this is a joint plan, and obviously it's been drawn up with social care and our colleagues from social services. But when you look at the detail in this, one of the greatest percentage of people who are delayed for going home or going to a next place from hospital is because of lack of social work assessment. I know this is 49%, I think it was. I can't find it now, but I did read it. So given that is the case, I do wonder why we haven't got social workers working on a 7-day arrangement now as a regional approach to the winter plan. Because social workers work 5 days a week, it would appear, and they're not being asked to work any further. Yeah. And I just wonder why that's missing, because that seems to be a crucial link that we need in this winter plan if we are to get people discharged at weekends. So that was one question. And then in the generality of it, again, I can't find it in the report, but I did read it down, was we talk about building capacity in community health and social care. Now, I don't doubt that is probably our general aim, but within a winter plan, how are we going to do that? What are the actions that are going to enable us in the short term over this next few months to build a community health capacity and social care capacity? Because frankly, I don't see it happening. Thanks.
I'll come back on those 2 points, Chair. So they are linked, those 2 points. So 7-day working is how we're going to resolve a lot of our urgent emergency care issues. We get all banked up over the weekend, and we know we come in on a Monday usually to a bit of a flux,
And generally that's because our services don't work over 7 days. From a local authority perspective, we can't discharge any patients to a care home or a nursing home over a weekend because they don't admit over a weekend. And as you say, social worker input over the weekend doesn't exist either. There are contractual issues in all of that. So where we ask our staff to work 7 days, it's additional. We haven't yet got to the point where we've got contracts for staff that work 7 days a week, other than those obviously in ward areas and hospital services. So everything that's in the winter plan at the moment takes us into, we need 7 day coverage. Now we may not need Saturday and Sunday to look like Monday and Tuesday, but Saturday and Sunday has to have an element of those core services in them so that we get that 7 day pull out of the system. That goes for ourselves, our local authorities and care homes. What we're trying to do from the winter plan perspective is have that dialogue with local authorities and with care homes to say, right, if it's a manager that you need in a care home on a Saturday and Sunday to allow those admissions to happen, can we fund that through our winter plan money if we get it? So that then we can trial and give it a good rub of, does it work? Does it make a difference? And then we can build sustainability for it going forward. Where we're trying to do with the capacity for health and social care services, we're trying to make it work as a system. Okay? Now, from a health perspective, we've got lots of pockets of really robust community clinical services out there, and they all work in silos. So we've got 8 virtual wards that do really, really good work. We've got acute clinical teams that do really good work. We've got clinical resource teams that do really good work, and we've got district nurses that do really good work. But they all work as 4 separate teams rather than as a single resource that is seamless for the patient and for the care that they need, and it's a step up, step down model. The bit that we don't provide, and it's the biggest issue for us, is the care element of that. And most of our patients, when they're discharged, they will have some clinical need, but most of them will have a care need. And until we can find that care need, that prevents us from maximising what we can do in the community. So again, the winter plan is how do we work together, whether it's to fund additional domiciliary care through the local authorities, whether that's a bridging model that we provide through our Home First model, what are the options for us to do that? It's in the winter plan. I had an interesting conversation with Andrew Jarrett this week because he questioned, why is it in there? What do you mean? I said, well, because we don't know at the moment if what's being commissioned by local authorities is the totality that's out there, or if it's all they can commission because that's all they're funded for. And if we've got more resource, we can start asking different questions then as to, can we commission more, commission differently, or is it all going to be, as I said, asking their current staff to work extra, work differently, that we fund in a different way? So I think until we've got an assessment of what funding is going to come to us this year, I think we all know what we need to do, and I think we're all on the right page. Local authorities and us have worked really, really closely, and there's very little disagreement by what our priorities are, to be fair. I think we're much closer this year than we were last year in that space. And last year we worked much better than the year before. So if you remember, I can't remember what years we're in now, but the year before last was horrendous over winter, and December the 27th is still quoted as the worst day in history from a health perspective. Everything fell over everywhere. Last year was much better for us, and that was because we had really good conversations with the local authorities to make sure their services ramped up until the very last day of the Christmas break, kicked in as quickly as possible after the Christmas break, and in between we worked together to do more. So I think we all agree with what we need to do. It is the funding element and then the collaboration to make some of that happen.
We've got Darren, then Anne Louise.
I wondered if there's an option which is a hybrid of 1 and 3, because we've got patients at the moment in not the best setting of care, first setting of care. And if we commission step up, step down beds, the first thing to do would be to move them from our surge capacity and commission more and more step up, step down care, which is probably better for them as an accountant's view of the world rather than a clinician's view of the world. I think there's perhaps a relationship between using the leverage of the step up, step down aspect to decompress some of the pressures we've got with people being cohorted as they are. So perhaps we can discuss outside, but just came to me as a possible solution.
Thanks, Darren.
Thank you, Darren. Anne Louise, and then Jean.
One of the proposals is really to try to make sure that patients don't come in, that they're managed at home. How are we sending up that message into the community in association with primary care so that patients don't, as soon as they have a snivel or a sore throat, think that they're poorly and they need to come in? Because that is something that I think over Christmas particularly, I know people then are concerned about whether they would have access to hospital. But how do we encourage them to stay where they are and take a paracetamol?
So it is a really important message. What we're trying to do, and we had a really good summit yesterday that consolidated all the actions that we took Tuesday and Wednesday to say, right, how do we make sure that we're better at this going forward? And one of the points we raised was the importance of making sure primary care is engaged in that process. So Dr. Kerry Todd, I was on the call with us. She's going to work with our teams to make sure that we've got those links through from a cluster basis and into GP practices. Where was I going next? I lost my train of thought. Bear with me. The other important part on that is that any conveyance to hospital is going to go through a navigation hub. Okay, so if GPs want to bring somebody in, and it's a healthcare, if a clinician wants to bring somebody into hospital, they will call in advance to the navigation hub, which is staffed by our clinicians, WAST, local authorities as well, included in this hub, so that we can manage the best option for those patients, and they only come in for what they need. So that, again, that's one of our actions that we're taking through winter. So, but you're right, it's really important that all of these points are conveyed through, and then obviously comms will have a really important role for us in getting that message through to the public as well. But we've got to make it work. So the minute it falls over, then the next time they're not going to ring, they're going to present at our front doors, and they will self-present. So if they think that they're being gatekeeped and they don't like the answer, then self-presentation at DD is what's going to happen. So it's really important we get all of the services aligned right, the comms aligned right, and it works.
It's Jean, then Helen. Jean, please.
Yeah, thanks for that, Chair. There's a huge amount of detail in there, Deb, as always. But one of the things for me when I was reading through that struck me, what are your desired outcomes? What are the measures of success? Because I don't think that was explicit, or when I read it, I had all the information of what you're doing, what you're planning, what the risks were, what the mitigations were, but I didn't see what you were achieving, what you aimed to achieve. So that was what was a key part that was missing for me out of that report.
So firstly, we need to make sure it's in there at the beginning then, because when it's submitted, that's the bit that's the really important step for us. I think what we're trying to achieve is clear, and we have got a clear alignment through the RPB space, and it is actually what I've said earlier, is we manage patients safely in the community as far as possible. They come to hospital for what only hospitals can provide, and for the short space of time that they need to access those hospital services, and they move back home or back into the community if that's a different home by way of the outcome as quickly as possible. What I want for the population is for all of that to be seamless. So there's one point of contact, and that is picked up and managed, and that step up, step down model is seamless for the patients and the carers. And at the moment, we've got real good core components of that, but it's not knitted well enough together to be seamless, and there are too many handoffs and that gap element of how we provide the care to keep people in the right place.
So am I looking for something that you can't give me? Because I understand that narrative about these are the statements, so these are the high-level statements of what we're trying to achieve. For me, as an independent board member, I would like to see the articulation of those stats underneath it.
Yeah.
So what does that gap look like? What does the, how is the healthcare acquired infections moving? What's the target? So that for me, that was the piece that was missing, was that analytical statement to say, this is what our measures of success look like, this is where we are, and that's the gap we have.
This is how we measure. That's a fair point, Jean. I will work with the team to build that for you. Okay?
I think it is difficult, Deb, isn't it? Because we don't understand yet how much resource Welsh Government may be intending to release, and it would only be on a non-recurrent basis. But it's about then, isn't it? Sort of how many admissions are we hoping to avoid? And of course, we did hear earlier that the issues in ED are not necessarily around the number of admissions, but how many are we hoping to avoid? By what number are we hoping to reduce people whose pathways are delayed? I think it's the quantification, so we could actually see the impact of all the hard work that's gone on here.
Yeah, and it'd be really important to get that baseline before we do any more anyway, so from our perspective, and we've got most of those measures in place. It's interesting that the stats between two local authorities are different as well when we're looking at pathway care delays, so they're obviously doing something very different. So the Swansea local authority, the number of days delayed is reducing for Swansea population, but the number of patients delayed is increasing. For Meath is the opposite. So the number of patients delayed is reducing, but the number of bed days that they're delayed by is increasing. So we're seeing the opposite per head of population between Swansea and Leeds, so we need to get them working more closely together.
And of course, there is this issue, isn't there, interoperability of systems, digital systems between ourselves and local government, which again we'll refer out to the committee outside the meeting. We've got Helen, then Richard.
I like the prevention bit and how you're going to measure how many people will stop coming in. And again, it's about the communication to the public. We're holding, Tess is holding an open forum for health and social care to come in and speak to the leads of the communities to say this is where you can go if you prevent, because sending a message by a press release or by a video is actually those communication, those talks with those community leaders to say, well, you can go here or you can go there for that. And you have been invited.
Yeah,
but, you
I'm
know,
coming.
But it is getting those leaders in to explain, because it's stopping those people coming in.
Yeah.
And then, you know, we don't want them stuck in there where they don't really need it.
Yeah, that'll be an interesting session, but I will be there. Thanks, Helen.
And sorry, on that, I presume whilst we're involved in your winter plans.
Yes, yeah.
Thank you, Helen. Richard, I'll give the last word to you before I ask Abby to sum up in terms of what we're going to do then as a consequence of all our discussions. Richard.
Thank you. I was just struck by Rina's comment and Deb's answer. We sometimes maybe assume that everything is clicking in place across 7 days a week as what business as usual might look like, and that's not the case. I was on call yesterday, and in the afternoon we had 2 patients who were due to go to a local residential home, but the manager was off for the afternoon, which meant they couldn't take either of the patients because the senior manager wasn't on site. And so Deb's point about we often don't have a manager in those care homes at the weekend is also the case if they're not there in the afternoon, and they're seldom there in the evening. So in terms of how that all clicks together to understand how we need flow through a process of, it's not necessarily 24 hours a day, but certainly 12 to 16 hours a day, we actually need to work with those partners as well to make sure there's a shared understanding of what can benefit the system. Because as Deb says, sometimes it's thought that we need an extra workforce in at the weekend. Sometimes what we need is just extended a bit during the week to which means we're better prepared for the increased demand of the weekend. So it is quite complicated. There's multiple different contact points and dynamics in it, but it's joining it all up and making sure we make it's the best bang for our buck really when that funding does come through.
That's next week then, hopefully. Helen, did you want to come back quickly before Abby summarises?
In winter plan, then obviously in winter people get more down, and I'm wondering where your mental health winter plan is. Have you got more capacity for patients coming through rather than they go through A&E?
Mental health support into A&E is in our winter plan. Right. Mental health outside of that isn't. I can pick that up for you. Thank you.
Abby, do you want to sort of summarise for us?
Yeah, thank you. That's been a really good discussion. And one of the things that strikes me is our ability to articulate right across the pathway. There was a conversation about primary care. So are we sure that we've got the capacity we need in terms of the urgent primary care centre? So if you can't get an appointment on the day and you feel you need to be seen because your GP's got no capacity, actually we're able to see you in the primary care setting. There's something for me about looking at our rates by clusters of over 65 admission rates, understanding if you look at some of the performance data and the performance reports, how much our admissions and attendances correlate with areas of deprivation. So what can we be doing to support those clusters in terms of managing in the community and managing the message and helping navigate. There's the work we're doing at a national level with WAS through the JCC commissioning to try and put as much front-end clinical assessment, at your point about the navigation, Deb, to make sure that patients are being triaged before being brought in so that they're getting signposted to the right service, whether that's our hot clinics or whether actually it's around some service in the community. And if you look at what's driving, respiratory is going up, so what more can we do in primary care around respiratory and things like falls? What is the fall pathway? We know what the areas are. What more can we be doing with WASP around the falls pathway? I think the issue around social work assessment at weekends, we know that the social workers are a really constrained resource. There aren't that many of them. I think we have kind of ideas about how many social workers there are. There aren't really very many of them. And the issue for me is actually about trusted assessment. And being really clear where you do or don't need a social worker assessment. And sometimes the social care assessment is about unlocking the budget and the funding and signing off from a professional point of view. There's something about how we flip that to get really timely trusted assessors across the service. And that leads into the kind of bridging service where actually we can get people in discharge to assess models so that we're getting people back out home. Which I think responds to that issue around have we got variability as our threshold for discharge. When you're assessing somebody in an acute ward, rather than in their home environment, that's a different kind of sense of how we might do those assessments. In terms of the specific options and conversation about next steps, so Jean, definitely more work as we've been talking about within the team around how we quantify some of the benefit and impact going through the winter. In terms of the request into Welsh Government, there are two things. There's refining the 50-day challenge plan through the RPB, which we're continuing to work through. And when we get the data, knowing how Welsh Government and the RPB interface works, we will be measured to the nth degree in terms of what that funding is going to achieve, so we can bring that back to colleagues. But secondly, there is a request to put into Welsh Government what we think we need by is it in closer play tomorrow, Deb, in terms of winter. So these options feed into that. Because we clearly have this challenge at the moment that we've got more capacity open than we have got accounted for in our financial plan. We'll need to work that through as part of the recovery and sustainability. But in an ideal world, yes, we'd be able to get more of the step down, step up capacity commissioned, but we may still need some of that surge capacity as we go through the very intensive weeks of around Christmas and into the new year. And we would hope that Welsh Government funding would enable us to manage that kind of flex capacity that we might need. So I think, Jan, that's where it takes us through the options. We will need additional funding from Welsh Government and have some very, if there's nothing forthcoming, that will be a difficult conversation about how we manage within the financial envelope we've got, and we'll need to keep very close to Welsh Government, different policy areas in terms of how we manage that.
So can I just check, if there's nothing coming from Welsh Government in relation to these options, we have to come back to this on the 19th of December,
Yeah.
and then board might have to take a very difficult decision around that. Is that right?
Yes.
Thank you. So this, the submission needs to go in tomorrow. So can we do what we can, Deb, in terms of what quantification can we put in the different components, just so that the board can be assured that, as Jean said, what does success actually look like? What are we hoping to achieve? As much as we can quantify, we do that. Are we happy to approve the submission on that basis then? And then, of course, as we've said, we need to know, when we know from Welsh Government what resource is coming, what impact it has on our options, we will be bringing that back in our discussions on the 19th of December. And of course, we will be closely monitoring this whole thing. And Steve, the Quality and Safety Committee will need to come in on this as well.
Sure.
Oh, we have, Jean.
One thing I forgot to say was, why are we planning for winter when we're going into December? Because it doesn't make sense to me.
And it won't be the case in 25, 26, Jean. We will be there at the end of the summer, right, starting for, because really it will be year round, really, really. But your point is very valid, and we're too late coming to this.
Could I just come in on that point, Chair, if that's okay? So you're absolutely right, Chair. It's seasonal variation that we see now. Last winter was no different to the summer in terms of demand and period. Now we know winter brings different challenges in terms of flu and viruses and some variation in that. But this year, August was the worst month of our year so far. Okay, so we know that it's a variation. The winter plan element obviously comes from challenge from Welsh Government as they want us to submit something specifically to address winter pressures. We have had the same dialogue with them, and they understand where we are with it. And originally, I think it was in the summer, we were told we didn't need to submit an actual winter plan this year, and then that changed as we went into August, and then we had the letter to say we needed to submit something. So some of it it's a requirement from us to submit a plan. That doesn't mean that going into winter we're not planning for what the variation that we get during winter, and we start that obviously seasonally going through the year.
Yeah, I agree with that, Deb. The only other thing I'd add to that is that what we know from the data is that the period over Christmas where we do not have the full complement of staff you'd expect. Clearly, we've got to have our ward staff, but we won't have, because of annual leave over the Christmas period, the full workforce you'd expect in the middle of September, for example. And therefore, that really intensive period that it takes quite a long time to recover from, potentially after, normally hits on the second of, well, it depends where Christmas falls in terms of staffing, but our ability to recover very quickly when we do have a tail off of beds over Christmas. I know we do have some admissions prior to Christmas as well, but for me, it's about how quickly recover in after the Christmas period, and that we can get traction on that really quickly. And that, I guess that's the one difference between the seasonal bit, because we do have this period where we know that the immediate post-Christmas week can be really challenging, and our ability to recover is where we need to really focus our attention to make the rest of winter as doable as possible.
For those of us who've been in the system a long time, we used to have a mass exodus on the Friday before Christmas or whatever it was. We'd have a mass exodus out of the wards. It'd be lovely and empty over the Christmas period, and then you'd come in and do it all in January. We don't get that anymore, so we don't get that mass discharges from we get more that they drop Granny off to stay with us for Christmas rather than take her home. So it's the dynamic has really changed from what we're used to seeing, but it is a constant delivery now.
And Jean, we'll add a point on to this in terms of the ask from the board of a whole annual approach to this with relevant seasonal adjustments. But if we can ask quality and safety as well to make sure that for the coming 25-26 season, we are well ahead of where we find ourselves now. Thank you. Well, we've done some really, really hard, complex work so far. I think we've all earned a coffee. So we'll have a 15-minute break, please. Thank you, Dr. Lowe.
It's funny, it's just I just no, and I so thank you very much, but mine I just unplugged it with my computer because it just said it was when
We okay, Claire? Okay, Professor Narbout, welcome back, everyone. And we've come back at point 4.6 of our agenda with the key issues report from the Quality and Safety Committee. And as again, you mentioned earlier, we're now operating on a AAA basis. So Steve, may I hand over to you then from the committee, please?
Absolutely. So as the Chair said, we're piloting this AAA approach. So what I'm going to do with the key issues reports is just talk about the alerts. There are two other levels of called assurance and advise, but unless there are any specific questions on those, I won't deal with them. And the team producing these reports is also learning how to do it. And so one of the papers only reached admin control this morning. So apologies for that. But we'll get there. And any comments on how these things are working and how chairs are delivering them would be gratefully received. So two meetings for which there are papers in admin control, and one meeting we had this week, but I've already got a report for that, so I'll touch on those. So the alerts from 24th of September, you're aware that the Quality and Safety Committee has assumed the work of the previous Health and Safety Committee, and every quarter we have a health and safety update. And it was noted as an alert that in that report there's been a large increase in violence and aggressive incidents across the piece, basically, and efforts are being made to deal with those things, but it's hard work, and when the health and safety guy comes back the next time, we'll be expecting positive action to have been taken to basically help protect our staff, because 95% of the violence and aggression is patient or member of the public or staff member. Sometimes member of the public or member of the public, but usually it's a staff member that's a subject, so that's a worrying thing. The other alerts that I'll mention, we talked about unscheduled care in other fora, so I won't go into detail. The NR Fit Safety Alert, this is a methodology of delivering medication. That shouldn't be an alert. I think it was typed into alert because it had the issue had the word alert in it. But actually we are complying with that safety compliance, and it's all going well. So that was from the 24th of September. From the 29th of October, there was a Never event. You're aware what Never events are. We'll probably always put that in an alert. But these matters are dealt with. This was a retained object in a patient, so it obviously should never happen. No harm came, but the object had to be removed subsequently. But these are always subject to investigation and learning meetings, and will be kept up to date. The committee will be kept up to date on what happened in that case, but in the case of all other Never events as well. In the Quality and Safety Performance Report, we've heard about neurodevelopmental issues this morning already. We've heard about cancer this morning. The other one I would draw your attention to is within mental health, which we'll be having a paper on later. There is a shortage of psychiatrists. Even in this room, there's a shortage because a psychiatrist has left the room. But there's a shortage of psychiatrists in the region, and so psychiatric assessments are running at a suboptimal level. And we've talked about the clinically optimized patients. The reports which our committee received highlighted all the changes that you've heard about this morning, all the changes in the system, but we also heard that the numbers remain stubbornly high. And this week, it was only 2 days ago we had our meeting. There were a couple of items for alert. One is there's a dental service, it's special care dentistry treatment, and this is for a very a small cohort of patients, only about 160 a year, and they are people people who require general anaesthetic in order to receive dental treatment, and these are people with specific needs or with behavioural issues. We've had to suspend that service. It can only be done in a hospital setting as opposed to a dental setting. It was previously being done in the Princess of Wales Hospital Eye Theatre. I'm not quite sure why it was the Eye Theatre, but you're aware that the Princess of Wales Hospital is having structural difficulties at the moment. So since October, that service has been suspended, and Carl Bishop, the dentistry director, hopes that it will be up and running again shortly, but for the moment it isn't. So there are a very small number of people, but with very complex needs, whose dental needs are not being met. And we also had an update report on the infection prevention and control issue we've already heard quite a lot about. And again, we are informed that we are not meeting our targets, and in particular, there are challenges with C. difficile, but the board is already aware of those things. So that is my series of alerts from the Quality and Safety Committee.
Thank you, Steve. Deb has already signalled in respect to the dentistry issue, but Sarah, perhaps I can then ask you to talk about the violence and aggression incidents in relation to impact on staff. Deb, do you want to talk us through
Thank you, Chair.
this?
I'm well aware of the special care dentistry issue, and as Steve notes, they're really a difficult group of individuals to manage, and the environment has to be absolutely right for them, because there's a lot of bedding in to make sure that we can be managed in a safe way. So we're working with Cwmtach Morgannwg at the moment to see if we can use Neath Talbot Hospital. So due to how some of their services have moved out and back into their own area, Theatre 5 with us at the moment, which is a smaller theatre that we can't do the big work that we do in Neath Talbot in, is largely available at the moment. So we look to see whether that could be used for some of their other services, but also to cover off the gap for special care dentistry. So hopefully we'll get that back up and running soon.
Thank you, that's really positive to know that. Thank you. Sarah, in respect of the 90% of violence being patient or member staff?
Yeah, absolutely. This has been an issue actually in terms of exploring within our deep dives in relation to sickness absence. So it's one of the top reasons in mental health services in particular that connects with the sickness absence issues, and the team are very focused on understanding those issues, supporting our staff back into work. So it's certainly something we're alerted to. Equally, we're very mindful of the risks in our ED department. In that respect, and about managing that and how we manage those carefully, concernedly. It's something that our Guardian service have equally picked up around that issue, and therefore it's about us working with our populations in terms of our communication, but also about how we support our staff in that respect. The Mental Health and Learning Disabilities team have done an awful lot of work in this space. In terms of helping to understand the impact on our staff and about how we support them back into work appropriately in those circumstances. It is something we have to increasingly keep an eye on, absolutely.
Thank you very much. Thanks, Sarah. Any comments or queries for? Yeah. Thank you very much, Steve. As ever, thanks to you and the committee members for the rigour with which you discharge your role. That's really great. Thank you. And now we move on to 4.7. And as you will see, the Ombudsman's asked that her annual letter is presented to the board. So Hazel will take us through that.
Yeah, so this is part of an annual ask that we require to put into our board. It's also gone to the Quality and Safety Committee and scrutinised there. Last year across Wales there was a 70% increase in contacts for the Public Service Ombudsman. 939 complaints were made about the NHS in Wales, of which 132 related to Swansea Bay, and 10 of those proceeded to formal investigation then. We have had some complaints upheld in relation to complaint handling, and we are going to put on complaints training out there for our staff in the service group. There were 3 public interest reports published last year by the Ombudsman, all of which related to orthopaedics and the waiting list management and action plan was developed and been implemented and overseen by the Quality and Safety Committee. 127 recommendations were made by the Ombudsman to the Health Board. We've completed 62% of those at the moment. I think a greater focus needs to be placed on those and completing them by the timescales we set. So we're going to do a piece of work around that. I think those are the main issues I wanted to highlight.
So was there anything you wanted to add from the quality and safety perspective on that issue and how you're exercising oversight? Because I know you've been looking at people waiting a long time for the responsibility.
You mean complaints?
Yeah.
Well, we had a deep dive into complaints at the October meeting, I think, and we were satisfied that the work being done is it's of high quality. I believe it's in our report under assurance, so it's good. It's good.
Thank you. Thank you. Anne-Louise.
Just a comment to say I congratulate Hazel and her team because getting the responses in time, as you have, and the paperwork in, is no mean feat. I know from my past job, and I think it's a credit to them that you managed to corral enough information to get it into the Ombudsman so that he can deal with it. So any delay is his, not yours. So well done.
Thanks, Anne-Louise. I'm sure that'll be great for you to see. Nicola.
Hi, thanks Hazel for the report. Just wanted to ask one quick question really. What do we learn from these complaints? So obviously trying to reduce them for future years.
Yeah, so that's an important aspect, and we take the learning and present them through Quality and Safety Hub, and they have learning sets. So there's a regular item there, learning from Ombudsman. But we don't just look at our cases, we look at across NHS Wales as well, and take the learning and share those in those community. It's a patient safety conference events.
So those are annual, aren't they? Are they quarterly?
Quarterly events, and we try and do a look back at Ombudsman and member events, but we also try and look externally at reports from across other health boards and drawing and learning from that as well.
Thank you. So if you could let independent members know the dates of the quarterly events, who's available to sit in on them.
Absolutely. Very welcome, I know. And Anne-Louise is keen to one. Yeah.
Thank you. Thank you very much, Hazel. We can take assurance from the work underway. Rena, shall I turn to you then in terms of workforce and OD, please?
Okay. This is my first committee, so I found it really interesting because obviously a lot of new stuff for me. The alert is in relation to the staff survey, because I know Abby's been particularly putting that in our message, is the slow uptake of staff and the keenness of us to try and get staff to actually complete the survey. I think the difficulty is, and I've already talked to the chair about this, is the fact that the survey is annual, which in some ways is probably quite, too often. And also, I think what became apparent in the committee was that the results of last year's survey didn't come out until well into this year. And therefore, the opportunity to do something about the things that were raised in the survey had not yet arisen. So in a way, you can see how staff would disengage given that sort of timescale. So I think the view of the committee was that probably an annual survey is too frequent. But whether we have any leverage in terms of being able to say to Welsh Government, we think it's too often. But I think the important thing is, and what we have asked, is that the areas that the service groups have identified that they need to do work on coming out of last year's survey, we've asked for reports to come forward to the next committee to tell us what they are doing on those areas. And they all were looking at about 3 priority areas really coming out of the survey. The only other quick ones on the assurance, we had a deep dive into reducing sickness absence, which is in maternity and neonatal on this occasion, but we are looking at it across the board in service groups in turn, and in particular in the hotspot areas, because I know estates has been mentioned as a hotspot area. And the other thing was in terms of what we're doing on the leadership and management development and the training programme, with particular reference to certain areas which we are concerned about, like financial training, which I know Darren is looking at with Sarah at the moment. So there's quite a workload building in terms of workforce and OD.
Thank you, Rena. And I know that, that committee is a developing agenda, really, all weighty items. Sarah, was there anything you wanted to add there?
No, just to reassure. So from a staff survey perspective, currently schools on the doors are at 11%. Obviously, you would prefer to be at a much higher percentage there. But respect the points that Rena said and fully support them and endorse them and recognise that is the discussion across Wales in terms of those concerns. In terms of sickness, really appreciating it's a real priority area for us and hence the need for us to ensure we deep dive within the ward committee for all of the areas and to ensure that we truly understand the reasons for absence, which are different in each of the service groups, and therefore the need for us to how we support our staff back into work, importantly.
Yeah, thank you. It is a really important opportunity for staff to give their feedback to us, and that we very consciously and purposely consider what they've given us feedback. I have a slightly different view on the annual. I think staff should expect to have a really good appraisal every year, and I expect that this is an opportunity. The issue is it needs to be practical, and we need to use it as trends and to show that we're doing something with it. And it should be, my view, it's quite long. There are lots of questions in there. I would rather have an annual rhythm, but it's shorter, so that we're getting into a pattern that you get your appraisal and you get another opportunity to anonymously feed in. But I appreciate that you might want to do something bigger and more comprehensive on alternative years, but having a different drumbeat. And the critical thing is that we can say we've listened, we've heard, we understand what you've said, and this is what we're going to do. We can't probably tackle everything, but it's part of the people and culture plan that we absolutely plug that in as part of the conversations and use other opportunities that we also get for where staff can feed in comments to us. So yeah, it's still work in progress, isn't it? But I hope we can nudge it up. Final day. I keep saying if everyone tells 10 people and they get 10 people, then you start to get the momentum. So, but thank you.
Thank you, Rena, and thanks to the committee as well. So Jean, can we turn to you then, please, and step into the chair of our new Digital Data Research and Innovation Committee, please.
Yes, thank you, Chair. We've had our first meeting, which we have to say the energy and enthusiasm in the room was palpable. So it's really pleasing to see how Matt and his team are looking forward to having their own bespoke committee, although it's got a rather large scope. And the innovation and research, we've yet to bottom out the terms of reference explicitly for that. But our first meeting, we had 2 areas of alert for the board, which was the clinical coding audit report, which had been referred to us through the audit committee. And the timescales within the implementation plan clearly would not be achieved due to financial challenges, including the vacancies within the team. So there was also a financial risk noted that was associated with this. The second risk was relating to the non-compliance with UK GDPR, which was being reviewed to reflect the challenges in the processing of subject access requests in a timely manner. That we are increasing the risk on the register from 16 to 20. So that should be reflected on the next risk register. In terms of assurance, the committee wished to assure members of the board that the financial management report was received and can be assured that the digital services capital and revenue positions were managed well. A break-even position was forecast within the capital allocation. Revenue was underspent and the required year-end control total would be met. There are robust processes in place throughout the digital transformation plan, and risks relating to the delivery of the projects were being well managed. The information governance report was received and the committee wished to assure the board that the risk related to non-compliance within the UK GDPR was being reviewed to reflect challenges in the processing of those subject access requests, as we've already mentioned. In terms of advising the board, there was a report on operational performance received, and there was a gap in funding towards the complex and resource-intensive systems disaggregation, say that after a drink, for the Bridgend boundary change, which is being escalated by DHCW to WG. So I'll say that again properly this time, that there was a gap in funding towards the complex and resource-intensive systems disaggregation for the Bridgend boundary. The committee endorsed the application form for the use of artificial intelligence, which was presented as part of clinical practice going forward. And there was quite a debate on that. It's a very comprehensive piece of work delivered by Raj. A report on the digital strategy development was received. The intention is to present that strategy and a costed 3-year digital roadmap for approval at the January board. So in terms of the review of risks, the committee reviewed the 4 risks assigned to it and would like to advise board that the risk related to non-compliance with the UK GDPR was being reviewed to reflect the challenges which I've already referred to. The risk relating to clinical coding was currently under review and was deemed appropriate to be included within the corporate risk register. The sharing of the learning that we felt we should advise board of was that staff and those submitting the reports and the operational day-to-day management would need to develop a deeper financial insight into all the activities within the department. As presenting their reports to the committee now, there will be a greater emphasis on the financial interrogation. So we discussed various ways of looking at financial impact within the department. The actions to be considered, we would like to notify board to consider, they will be asked to consider the annual incremental increase in allocated spend that will be required to ensure the health board optimises its digital potential for current and future demand. That information will be brought to the board in January.
Well, we thought it was a good idea to introduce this committee, and obviously your first report to the board, Jean, just demonstrates exactly that. And you've clearly covered such a wide range of subject matter. Before we open it up wider, Nuri has asked me to ask one thing, and it's around the limited assurance on clinical coding. And in respect of the audit committee, she wants assurance that the report will be coming back to audit committee with revised timeframes. Is that correct? So can we relay that to her?
Yeah, that's absolutely fine. I mean, I could go into a little bit more detail on that if you like. But,
okay, there we are. So we can perhaps pick that up outside with Maria. But she specifically wanted me to ask that. So is there anything you want to add to Jean's summary before I open it up more widely?
Yes, just briefly. I think in terms of a first committee, I think from my perspective it went very well. I think it was a good mix of both operational and strategic oversight. Papers were maybe a little bit longer than we'd like them to be moving forward, but I think it was important to paint some of the background and context to the committee so that everybody was aware of some of the complicated backgrounds that we've been dealing with. There are a number of elements to the paper, so I won't go into each one and just allow questions around them. The only area I wanted to just say a little bit more on was the digital strategy. So just to give a little bit more detail, so the intention is to bring the digital strategy to the health board in January, which will be a 10-year high-level strategy with the aspirations of what we want to, where we want to be over a 10-year period in the health board. There will be indicative investment costs in that and indicative benefits over that time, but the more detailed level of this will be in the 3-year plan, where we aim to identify, and particularly given where we are financially, the first 3 years of this plan will put a key focus on efficiencies. So that